Thank you again. As Donald has said, we are going to be having a wonderful series of presentations this morning. The first is going to be from acne to acne from adolescence to adulthood. Dr. Carrie Clark, who is from the Dermatology Association of Jamaica. And Dr. Clark was trained at the University of the West Indies and completed her dermatology training at Boston University Medical Center. She has gained significant clinical experience over the last 12 years working as a dermatologist, both at University Hospital of the West Indies and Kingston Public Hospital. She enjoys educating about skin disease and has special interest in clinical dermatology. At this time, I'm going to hand it over to Dr. Carrie Clark. Welcome.
Hi, good morning. Thank you for inviting me to your meeting. Today, or let me just try and share the screen. All right, just checking. Are you seeing my screen? Everybody?
Yes.
Okay. All right, so thank you. Thanks again for inviting me. Today, I'll be discussing acne from adolescence to adulthood. All right, so this is a long topic, so I'm trying to touch a bit of every aspect. We're going to go through our objectives, which would be to discuss the epidemiology, the pathogenesis, clinical features, treatment, natural treatments as well as diet and acne. And thanks to the pandemic, we have a bit of masking going around, so we're going to talk about that as well. And so we're going to talk about acne vulgaris. There are multiple types of acne. Acne vulgaris being the more common type. And the definition of this is a chronic inflammatory dermatosis, notably for open or closed comedones. So the open or closed comedones part is very important when we're seeing our patients because not everybody who comes into our practice with papules on the face will have acne vulgaris. But once you're seeing open or closed comedones, that's basically pathognomonic for acne. We're also having some inflammatory lesions in acne. You're having your papules, your pustules, nodules, as well as cysts. Acne is very common. Most of us will see this. Definitely, I can't remember a day when I've seen patients and I'm not seeing at least one patient with acne vulgaris. It occurs in about 85% of individuals between the age of 12 to 24 years. You can see acne in neonates, and this is usually due to the hormones passed on from the mother, so this is self-limiting, but most times acne will start between 12 to 24 years. It's not limited to the adolescence. It can occur at any stage, and it will continue into one's 30s and 40s as well. So let's go a bit into the pathogenesis. Now, acne is multifactorial, but the important issues in acne are occurring at the pilosebaceous unit. So this is between the hair follicle, and this is the sebaceous gland attached to the hair follicle. And what we have going on here is that we're going to have increased sebum secretion. And this is usually during puberty under the influence of our androgens. We're going to have occlusion of the pilosebaceous orifice by a keratinous plug. We're also going to have colonization of the pilosebaceous unit by your microorganisms, notably your Cutibacterium acnes. And then with all of this, you're going to have release of your inflammatory mediators, your cytokines, into the dermis when your gland ruptures. Now, the pathogenesis is important because that's going to help you with management of the patient. If you can understand the pathogenesis, you can understand the different treatment options we have available for acne. So like I said, it's multifactorial. Multiple studies have suggested that there are neuroendocrine regulatory mechanisms that play a part. Studies now are showing that diet play a part. There are multiple genetic factors associated with acne as well as non-genetic factors. So let's go on to our clinical features. So remember, when patients come into the office with acne, we're looking on the areas that are riddled with sebaceous glands. Okay, so we're looking on the sites with the face as well as the upper trunk. And this is important because most of our patients will come in, they'll tell you about the acne on the face, but unless you get them undressed, you won't appreciate the lesions that are on the upper trunk as well. You're going to be looking for your really what we call our pathognomonic lesions, such as your closed comedones, also known as whiteheads. You're looking for your open comedones. If you see this, you know that you're dealing with acne lesions on the face. They're also going to have erythematous papules and pustules. Patients would have nodules and cysts. And they will have excoriations. Most people think that they can remove the acne. So they'll go ahead and do so during the course of the illness. The next very important lesions that I want to point out would be your post-inflammatory hyperpigmentation. This is very important because this lesion, along with scarring from the acne, is probably more distressing to the patients than the acne lesions. When they come from the first visit, you're going to have to acknowledge that you are aware of the PIH lesions and the scars, because by the second or third visit, when you have control most of the pustules, the papules, and the comedones, if they're still having PIH and scars, they might not be very satisfied. And I just want to make note about patients with skin of color. These patients are going to have less erythema. Just as with other dermatosis, you're not seeing as much erythema as you would associate with the inflammation. You're looking for a more violaceous or a gray look. And in our population, with patients with skin of color, there's definitely more post-inflammatory hyperpigmentation. All right, so this is a patient, and I hope you can appreciate that this patient has some open comedones here. They also have some papules, and like I said, patients of skin of color, you're not really seeing as much erythema. They're having hyperpigmented macules, and they're also having hyperpigmented papules. This is another patient. This is probably more the category of moderate to severe acne. This patient is having more pustules, the erythematous papules. So you're not really seeing as much redness, but like I say, you have to appreciate that the normal skin is a little less red than this. So it's more violaceous. This patient, even after treating and getting rid of all these papular lesions, you're still gonna have significant hyperpigmentation left. And this patient also has significant amount of acne scarring that at some point would have to be addressed. So in the Caucasian patient, you will see more redness, and this is a nodular cystic lesion, seen more in severe acne. Go on to the next patient. So this is what I'm talking about, and this is not even a severe case. This is a patient whose acne is pretty much controlled, but they're still having significant PIH, and they're very concerned about the scarring, and this is something that's going to keep the patient coming back to the office over and over. So the next set of patients that I'm going to show you are patients who have papules on the face, which are not acne, okay? So remember I told you that you need to look for your comedones to help to make your diagnosis, and also the history of the acne lesions. Acne lesions they come in crops, they come, last probably 1 to 2 weeks. So if the patients are having papules on the face that they've had there for months and they haven't moved, they're likely not acne lesions. So this is a young boy. He's probably about 6 years old. And with this patient, at 6 years old, if you're convinced that it's acne, you probably need to send this patient to rule out precocious puberty. This patient has brown papules that are on the central face. He has the same lesion actually as this older male. He has these brown papules, the central face, they're also becoming more confluent. And if you undress this patient, you'll see other stigmata of this disorder. These two patients actually have tuberous sclerosis, and these are angiofibromas. Okay? You probably won't see this commonly, but the next lesion you will see commonly. This is cream-colored papules, and this is in a patient who will tell you that these papules have been there for a long time. They have not moved. This is milial, and it's associated with keratin being trapped in the skin. I see this a lot along with acne lesions. So if you see this with acne lesions, you have to tell the patient, well, the acne lesions might improve, but this might stay a while. This might actually need to be manually removed. And it's seen a lot in patients who use bleaching creams. So this is another patient with papules on the face. These are more dome-shaped papules, and some of them are excoriated, and I don't know if you can appreciate the umbilication. This is a patient with molluscum contagiosum. This last patient, he might not so much confuse with acne. I think most times I would be referred this as a dermatitis, but these papules are flat top papules, and this is a patient with plain warts.
Sorry, Carrie, just your voice is dropping at certain points.
Okay, all right. How am I fixing that now? Are you hearing me better now?
Yes, much better.
Okay. So this is a patient with papules on the forehead, and they're flat top papules. So this is a patient who has plain warts. The last two patients will be challenging even for the dermatologist. This is a patient with pruritic erythematous papules and pustules on the forehead. This is a patient who is failing acne therapy, and at that time you would have to reassess the diagnosis. This patient actually turns out has pityrosporum folliculitis, and you can either try and treat clinically if you suspect the diagnosis, but you could do a scraping, a Carrie scraping, and you will identify the pityrosporum organism responsible for these lesions. So this is another patient, a challenging patient, a patient who has had acne in the past, has been on multiple oral antibiotics, now failing therapy, not improving, a lot of pustules, papules, nodules, and cysts. And this you would benefit from sending off for bacterial culture. This patient the culture will come back showing gram-negative bacteria. This is a patient with gram-negative folliculitis, usually treated with culture-directed antibiotics, as well as you can give them oral isotretinoin. So as far as investigations for acne, truthfully, acne is a clinical diagnosis. We don't do a lot of investigations. No routine bacteriological testing, only in, like the last patient that I showed that had gram-negative folliculitis. Also, a lot of patients will come, they want hormonal testing. Acne is really hormonal to begin with. So we don't need to do routine endocrine evaluations for patients, except for those patients that you believe have clinically have signs of androgen excess. And these are the patients who will have hirsutism, they might have truncal obesity, they have refractory acne lesions. Other clinical features, they would also have irregular menses, right, and possibly infertility. And so majority of the patients will fall in the category of polycystic ovarian syndrome. And truthfully, a lot of patients with polycystic ovarian syndrome are diagnosed first by the dermatologist, because at the end of the day, they're coming in with the acne lesions. That's what's bothering the most earlier on. Later on, when they're trying to have children, then that's when the infertility would be a problem. But initially, they're presenting with refractory acne. So treatments. Before you treat, it's very important to review your patient's skincare routine. You were probably not the patient's first stop. They probably did ask their friends, they went to Google, they went on YouTube, and they went around the pharmacy a couple times and got multiple treatments. You want to know that when the patient leaves your office, they're only on medications that won't worsen their acne. They're only on treatments, that won't worsen your acne. You want to make sure that when they leave, they're using gentle cleansers, that they're avoiding their scrubs, brushes, the multiple astringents, because trust that they're at home scrubbing away the acne lesions. And these abrasive cleansers actually worsen the acne. They cause more introduction of bacteria and they cause more inflammation. The cosmetic products, very important. You want to let your patient know that all the cosmetic products should say non-comedogenic. If they're using makeup, which you can't convince, I like when patients stop there using their makeup once I'm treating acne, but they want to put the best face forward. They're not really hearing you at the first visit. So you need to make sure that the makeup is non-comedogenic, like probably using mineral makeup. You want to tell them that they can't extend the shelf life of the makeup. They can't have a foundation that should be used for 3 months and be using it for 1 year. They want to make sure that they're keeping their makeup applicators clean. So their brushes and their sponges need to be clean, or they're just going to be a nidus for bacteria. Also, when you ask these patients about all the treatments that they're using, you kind of get an idea of the sensitivity of the skin, so you know how to start your therapy. They will tell you, okay, maybe they used benzoyl peroxide and the skin was very irritated, or salicylic acid and it was burning a lot. These patients, you probably need to evaluate, because in our population, they might have seborrheic eczema as well. So what are our treatments? You have first line treatment, and it's divided into mild, moderate, and severe acne. The mild is mostly comedonal, with your moderate, mild, less than 20 comedones or so. Moderate, more comedones, more inflammatory lesions. And your severe would be more like a nodular cystic acne. So for your mild lesions, you're using mostly topicals, right? By moderate, you're starting to add a little oral therapy, your oral antibiotics or your hormonal therapies. By you reaching severe, the severe section, you're probably considering starting these patients on oral isotretinoin. So let's just go through the recommendations here. Wordy slides from now, but if you just listen to me, we'll actually hit most of the important points. All right, so benzoyl peroxide, as far as topical therapies are concerned, okay? First slide are topical therapies. Benzoyl peroxides are recommended for monotherapy for acne. Reason being is that it doesn't cause bacterial resistance. You can also use it in combination with other topicals. So you can use it in combination with clindamycin is what we have available, or you can use it in combination with your topical retinoid. It's also advised that you use it with your systemic antibiotics to prevent bacterial resistance. Your topical antibiotics, not recommended for monotherapy, because then you'll be promoting bacterial resistance. Topical retinoids that we have available are adapalene and tretinoin. These can be used as monotherapy, and you can use them in combination as well. I think they're very good for patients with post-inflammatory hyperpigmentation, and they also help with scarring as well. The recommendation is that most patients should have combination therapy for acne. And of note, pre-adolescent children will benefit from using, you can use topical adapalene, the topical tretinoin, as well as benzoyl peroxide safely in this age group. There is limited evidence to support other topicals such as sulfur and zinc. And when you're using the topical therapies, it's more of a step-up approach. So your tretinoins come in 0.025, 0.05, and 0.1. It's best to step the patient up. So you start with 0.025, then you go up over time. I remember these take a while to work, so you're not increasing every week. You're going to give the patient at least 4 to 6 weeks. Systemic antibiotics, the recommendation is that you're using it for moderate and severe acne. You're not using them in monotherapy because you want to prevent bacterial resistance. The other thing that you're going to do to prevent bacterial resistance is that you're going to use it in conjunction with other topical therapies, such as benzoyl peroxide or a retinoid. You also need to have a topical therapy on board, because when you're evaluating this patient in 3 to 4 months' time, at this time, if they're improved, you're going to stop your oral antibiotics. And then they need to have some topical on board. So your first line topicals are going to be your doxycycline and minocycline, the group of tetracyclines. I tend to use doxycycline just because of affordability. The other orals recommended for acne will be your macrolides. You can use erythromycin or azithromycin. These should be second line. So it's only for patients who cannot use the tetracyclines. Emycin we don't really use because of increased risk of bacterial resistance. We're moving on to our hormonal agents, and these are basically our anti-androgens. So we're using your estrogen-containing combined oral contraceptives, or what's recommended for the treatment of inflammatory acne. You can also use spironolactone. This is useful. And remember, these are used in female patients. When you're going to use your combined oral contraceptives, you need to take a look at the contraindications, right? Everybody has their preference. Like for me, if they're smoking, no matter what the age, I really don't bother with the contraceptives. I will just possibly just move on to spironolactone. Isotretinoin, this is basically considered the cure for acne. It's recommended for treatment of your severe nodular acne. But you have patients with moderate acne who are treatment resistant, or they have a lot of scarring. You know that the scarring is long-term, so you need to be more aggressive with these patients. And these are patients that you would start oral isotretinoin on sooner, especially if patients are having significant psychosocial distress. These patients who are on isotretinoin, they need lab monitoring. So you're going to be looking on doing liver function tests, serum cholesterol, and triglycerides. And the recommendations, no, you don't really have to do them as often as they initially recommended. But these patients of females of childbearing potential need to be counseled on at least 2 acceptable methods of birth control. So now we're moving on to our natural treatments. There's growing interest in this because treatments are expensive. The treatments tend to be long-term. And of course, everybody is concerned about antibiotic resistance and what they're taking in and the long-term effects of the oral medications that we're giving the patients. So most of the treatments, the natural treatments, are anecdotal. So patients would have used, before they come to you, probably black soap, turmeric, tea tree oil, to name a few. But our biggest contenders will be niacinamide, which is anti-inflammatory, anti-carcinogenic, anti-aging, and also has moisturizing properties. Zinc is also used as a contender. It has fewer studies. They did a head-to-head study with minocycline and found that it's not as efficacious. At the end of the day, it has more GI side effects than even the minocycline, so it's not really used. Probiotics, we're using this in multiple disciplines because it helps the host to improve their own microbial balance. So in summary, for a natural treatments, we need additional studies for these. Current data supports niacinamide and probiotics as adjunctive treatment. The good thing with niacinamide is that it also has anti-carcinogenic properties and anti-aging properties. Probiotics, this is good to take with your oral antibiotics, right, to reduce antibiotic-associated diarrhea and like vaginal candidiasis. Zinc, not such a good option, not enough data supporting the use and too much side effects. As for diet and acne, so diet and acne has flip-flopped through the years, and the American Academy of Dermatology recommendations for this is that there are no specific dietary changes in the management of acne. Emerging data suggests that a high glycemic index diet may be associated with worsening acne, and there's some limited evidence that dairy, especially skim milk, may influence acne. What I usually do, like patients will actually come in, they have their own preconceived notions. They will come and they will tell you, like, if they eat a certain, a lot of chocolate, etc., the acne worsens. And if that is working for them, then you can continue. Other patients who are concerned, I will, discuss with them the data. If they want to do a dietary change for 3 to 4 months, if there is improvement, then they will continue on the dietary restrictions. And if there's no improvement, I would suggest that you just go back on your regular diet. So last topic we'll be discussing will be mass knee, and there was a recent publication in the JAD on mass knee. they actually came up with a diagnostic criteria, which they suggested that this will be onset or exacerbation of acne over the area covered by the mask, which is really your ozone here, within 6 weeks of regularly wearing a face mask. And you need to exclude other lesions that occur in the ozone, such as perioral dermatitis, before you decide that the diagnosis is maskne. Based on observation, they've decided that maskne is really caused by the occlusion, the friction, moisture, and heat from wearing a mask. And patients are going to come, you're going to have to tell them how to treat or how to alleviate maskne. They need to cleanse daily. They should maintain a skin barrier. So they need to moisturize before and after wearing the mask, and possibly several times a day. They should skip makeup under the mask. And if they have to wear makeup, at least wear non-comedogenic makeup. Skipping chemical sunscreens under the mask will also be of benefit. They need to take 15-minute mask breaks every 4 hours if possible. And this is important just for general occupational health. I think everybody should just take regular mask breaks. They should use a new disposable mask every day. Most of us, I don't think we're able to do that. Or you wash your cloth mask daily. So patients will ask you which mask is best. And their recommendation in the article is that you need to find a mask that fits snug but comfortable, not too tight and not too big. And I know we see one of either all day, every day. The best fit to prevent maskne will probably be surgical mask. And then you have your synthetic, your new group of synthetic biofunctional textiles, which are just treated masks that improve the cooling and evaporation of the mask. Then as far as the rest of the fabric mask, your next best bet will be a natural cotton or silk. And the worst of the line will be your synthetic mask. So in summary, acne vulgaris is an extremely common dermatosis, and it mainly affects our adolescents, but it can persist, begin, or become more severe in adulthood. It's multifactorial, and diagnosis is usually made clinically. Treatment is going to depend on the age of the patient, the sex, the extent, and severity of acne. And for most patients, we're going to recommend combination therapy that's going to target the different aspects of your acne pathogenesis. Thank you. Thank you, everyone.
Wonderful. Thank you so much, Carrie Ann. I really appreciate you sticking to your time, yet giving us so much information.
Yes.
We do have a question and answer session right now. And we have 2 questions. Let me just go ahead and get these questions. Okay. So first of all, Nastasia Wade-Sadler asked, what was said about acne and eczema? How would you treat that? I guess that's the question with the combination of sebderm and eczema.
All right, so when patients have seborrheic eczema as well as acne, the acne medications tend to be very drying. So if you go ahead and go aggressive with the acne treatment, you're gonna aggravate the seb eczema, and then you're gonna see more scaling and more fine papules coming on the patient. They're gonna be resistant. They're not gonna want to try your acne medications next time. So the plan is, what I usually do, so everybody has their little, their own little treatment plan. But what I usually do, I usually treat the eczema, which usually is seborrheic eczema first, or let them use the seborrheic eczema probably for a week or 2 before they start the acne medication. And when they start the acne medication, I go really slow, possibly telling them to use it every other day first. And I want them to moisturize and definitely use a gentle skin cleanser. You don't want them using any harsh products, especially when they have eczema.
Great, wonderful. We have another question from Andrew Burton. He asked, for oral antibiotics, what is the recommended duration of treatment? And in addition to that, we have someone asking if clindamycin, oral clindamycin is an option.
Okay, so the recommendation for treatment is 3 to 4 months and then reassess. That's a recommendation to prevent bacterial resistance. And remember, you're going to be using topicals in conjunction. I usually treat them at least for 6 weeks before, because you're going to need to treat them. Most therapies, you need to start for 6 weeks before you're going to see any significant improvement. Say doing a 1 or 2 week, which we usually use to treat bacterial infections, is not going to work with acne. But you don't have to use antibacterial doses like doxycycline. You can use 100 milligrams once a day. We don't have the presentations that they have overseas. They have a 40 milligram dose as well as a 20 milligram dose of doxycycline, which makes it more anti-inflammatory, less antibacterial effects. So then you're preventing bacterial resistance. As for clindamycin, yes. So we have dermatologists who have used clindamycin for acne, but like I said, the recommendation is to stick with the tetracyclines for first line. Second line will be a macrolide. The other antibiotics are not so much recommended because of the issue of bacterial resistance.
Okay, great. Thank you so much. We have an anonymous attendee who says, I've been through all the treatments of systemic and topical antibiotics, isotretinoin usage during adolescence. I'm now in my 30s and still have mild acne, but a lot of hyperpigmentation. What would you suggest?
All right, so we had a lot of patients who would come in and they were on oral isotretinoin, which I did say was a cure for acne, but they found that initially our dosing was not adequate, or the length of time that we treated the acne for wasn't adequate, because now they do say you can dose with oral isotretinoin for 120 to 150 milligrams per kilogram, which is much higher, and you treat the patients for a longer duration. Some authors suggest you treat them for up to a month after they have cleared. So the truth is that we find a lot of patients who initially were treated with oral isotretinoin, they're still having acne recurring. And the truth is, even when you do dose appropriately and for the appropriate period, there are still patients who will develop acne later on. If it's mild acne, topicals should assist. And remember, you do have to reassess that these are acne lesions that you're dealing with. You know, I just showed you a case with a patient who it was indeed pityrosporum folliculitis. They weren't acne. So you would have to be seen by the dermatologist, reassess the lesions, ensure that they are acne-informed lesions. I'm sure there's some topical, there's a treatment for everybody. And of course, there are other treatments that we use. There's light therapy that I didn't get to discuss. There are chemical peels. I didn't get to discuss those. So there are other things that we have that can be used to treat acne.
Okay, and that's for the post-inflammatory hyperpigmentation, the peels.
Yes, PR, microneedling, PRP. Skin lightening creams, I don't suggest for the PIH, because most of them actually, like some of them, to make them tolerable, you have to use a steroid mixture in it. And the steroid mixture itself would promote acne. Retinoids work very well to help with the PIH. You can use chemical peels. Some people do microneedling for the post-inflammatory hyperpigmentation as well. Okay. And great. Sunscreen, let's just say everybody should wear sunscreen, because if you're even sitting inside, you get invisible light rays, and that's going to worsen the PIH.
Okay, that's interesting. Sitting inside still needs sunscreen.
Yeah, you still have invisible light. People always come into my office and trying to tell me, I don't want to hear it at this point, that, oh, they've been inside, they're not getting no sun. You're getting sun, right? You're getting some light, and you're getting some hyperpigmentation induced by this light. So yes, you need to put on your sunscreen.
Okay, good stuff. Alicia Noseworthy Cox, for teenagers, what would be the best daily cleanser to use?
So this is a hard question, right? Because I do not recommend the best cleanser or the best sunscreen or the best soap. I think every patient needs to find the one that is the best for them. Okay, because some people, you give them a cleanser they don't like, the texture of it. They don't like the smell of it. It's aggravating their sinuses. They have a greasy feel. So the best cleanser you can look for a mild cleanser, especially if it says that it is hypoallergenic. Remember I said all your products should say non-comedogenic. So unfortunately, it's kind of like an expensive experiment, right? You're kind of going to be trying one, and if you don't really like it, you might have to just try another. But there are a couple of good ones. I don't really like to call brand names, but there are a couple of good ones, and I know that most of you know them. So once they can be used for eczema, they're actually pretty good for acne as well. And so you just have to go on and try. Some of them have acne medications in them, which will work, but some of those can be irritating, especially if you have eczema on board. So I would try one without any acne ingredients initially, and then if you want, at some point, you can step up with one with acne ingredients.
Okay, great. I know Boratel Neem Cream is where you're going to be doing a presentation, so you can let us know about that. I have a question here from Christy Smith. I did not hear salicylic acid mentioned for treatment. Are there any studies between salicylic acid and benzoyl peroxide for acne? And which one would you prefer?
For treatment of acne, I think more studies will support your benzoyl peroxide. For treatment.
Okay. And that would be for adolescents as well?
Yes, because benzoyl peroxide actually targets multiple arms of the acne pathogenesis. So it's a good, remember I said that of the topical therapies, there are only 2 monotherapies that I really suggest. And benzoyl peroxide is one of them. And it's an easy fix because you can't get it over the counter. I remember it's even the active ingredient that was a brand name, that everybody goes out and gets before they come to the dermatologist.
So they've already been treated with the benzoyl peroxide most times. Okay, great. Does acne ever burn out? That's another question that we have here.
Yeah, most definitely. You have patients who you just don't see them come back. It does. Usually when you get it in your teenage years, probably by your 20s, it goes. So it does burn out. It's distressing for the patients who they're, because you do call it teenage bumps. So when you reach your 20s and your 30s, you're like, why are they still hanging out? And there's some people, probably just pregnancy provokes it and then they don't see it again. So yes, there is hope that you won't have to be visiting us forever and ever.
Okay. If you still have it in your 30s, this person is asking, does that mean that they're going to have it forever?
No, it really doesn't. And then remember, it's multifactorial. So the truth is, you might just be doing something that's provoking acne. Some people get up in 30s and decide they need to go to the gym and run a marathon, and the occlusive clothes and the extra sweating with gym activity will aggravate your acne. So sometimes you just need to tweak something in your lifestyle. Maybe you decide to style your hair differently using more gels or certain products that are aggravating your acne. And you just need to tweak that and it will improve.
Okay, great. Thank you very much. I think we've seen one question here. Somebody says she's 47 and still having acne. So go and see Carrie Ann Clark.
I do this all the time when patients turn up and they're upset, and you need to tell them why they're having the acne. And we need to treat because they never had it, and they're going to tell you over and over they never had it before. So why is it here now? And you need to tell them the one answer. Really, there's no answer. Just like, children, 8 years old, that was my cutoff some years ago for precocious puberty. And I keep sending them to the pediatrician, and pediatrician keep sending them back and saying, there's nothing wrong, right? They're just having acne earlier, and we're having acne later. Okay. Of course, then there's some people that need to do hormonal tests, okay? Especially if it's refractory. So yes, when you reach a certain age group, I might try to look if I see any other causes of hyperandrogenism.
Great. Carrie Ann, thank you so much. That was comprehensive, to the point, and we really appreciate your participating in our conference this morning.
Yes, thank you for having me. Thanks for inviting me.
Okay, great. We want to continue to thank our session sponsor, who is Arista Pharma. And we are now going to move into our second presentation, and that's Dr. Stephanie Smith-Matthews, She'll be talking about acral lentiginous melanoma, a diagnosis not to be missed. She's also a consultant dermatologist with Dermatology Association of Jamaica. Dr. Smith Matthews has a BSc in biology from Bay Path College in Massachusetts and an MBBS from UWI. She went on to receive her master's in dermatology at the Boston University School of Medicine and further subspecialized in cutaneous cancers. Dr. Smith Matthews was the recipient of several awards during her time there, including the Marie France Demare Award for Humanism in Medicine and the Nancy and G. Robert Baylor MD Distinguished Clinical Scholar Award in 2018. Dr. Smith Matthews' special area of interest is in the diagnosis and management of skin cancers, including cutaneous lymphomas, as well as general dermatology. We welcome you now, Stephanie, and go ahead, and we look forward to your presentation.
Good morning, Dr. Swaby, and good morning to everyone. Thank you so much for having me. This morning, I'm going to be talking about acral lentiginous melanoma, which is a diagnosis not to be missed. So we're going to jump right in and get started. So I'm going to start by presenting a case of a patient that we recently saw in our cutaneous oncology clinic at the University Hospital of the West Indies. This patient is NJ, a 69-year-old male who came to us with an 18-year history of a dark spot to the sole of the left foot. And yes, you heard correctly, it's 18 years. So he told us that this spot began increasing in size and ulcerating over the last year. He had been to a couple of different doctors and was told that, as he put it, that he had arterial disease. And what we saw in his notes, he was being managed as peripheral vascular disease. So let's take a look at what we saw when he presented to us. So this is the plantar aspect of his left foot. Here you can see that we have a black patch. Of course, there is some variation in color. It involves the plantar aspect of the foot as well as the digits. We have a closer photo from a different angle. You can see here the black patch. It has variations in colors from some dark brown, tan brown, and then very black areas. It involves the web spaces and, as I mentioned, the digits, and there are areas of ulceration. Here you can see the sutures of one of the sites that we biopsied. So when we see a patient like this, there is only one diagnosis that comes to mind, and this is melanoma until proven otherwise. So, of course, our next step would be to do a full clinical examination. He did not have any other suspicious lesions elsewhere on the body because a full body skin examination was performed. We also at that time would perform a lymph node examination. And what was found was that he had large matted non-tender inguinal lymph nodes on the ipsilateral side. So on the same left side, he had inguinal lymphadenopathy. Where do we go next? Of course, our next step in management would be to confirm our diagnosis. And so we did 2 punch biopsies of the left sole. Remember in our picture, I showed you where we did biopsy here, and I think we also did of the ulcerated lesion as well. And we'll talk a little bit more later on about how we choose these biopsy sites. So our pathology report came back showing an acral lentiginous melanoma. The greatest thickness, or the Breslow's depth, is greater than 1.7 millimeters, so quite a thick melanoma. Other things that we look for in our path report, which we'll discuss later, is if ulceration was absent or present, and in this case, it was present. So preliminary, our pathologic stage would be T2B, NX-MX, and we'll talk a little bit more about why this is relevant. But before we do that, let's just talk let's just remind ourselves about malignant melanoma. So these are malignant tumors that arise from our melanocytes, which are the pigment producing cells of the skin. It's most commonly cutaneous in origin. However, there are other sites that may be involved, and these include mucosal surfaces, including oral, conjunctival, and vaginal. It can occur in the uveal tract of the eye, and of course, the leptomeninges. It is an immunogenic tumor. And what do we mean by this? So clinical observations such as incomplete or complete regression of melanoma has been observed. There's also an association with the development of vitiligo-like depigmentation, especially with treatment with immunotherapy. And of course, its association with halo nevi. Also, there has been shown that there is a higher incidence of melanoma in immunosuppressed patients. The incidence rates over the last couple of years have increased worldwide. So just to mention that the Breslow depth is the most important local prognostic factor in primary cutaneous melanoma, wherever they are located on the body. The types of primary melanomas include the superficial spreading melanoma, which is the most common, nodular melanoma, lentigo malignant melanoma, and acral lentiginous melanoma, which will be our focus this morning. But as I mentioned, the Breslow's depth is the most important prognostic indicator, regardless of the type of primary melanoma. So our acral lentiginous melanoma, or for short ALM, it typically occurs on the palms and the soles, or in and around the nail plate. It's diagnosed most frequently in the 7th decade of life, although we do see them occurring from age 50 onwards. It accounts, so acral lentiginous specifically accounts for approximately 5% of all melanomas. As I mentioned before, superficial spreading melanomas are the most common type. However, it's disproportionately represented compared with other melanoma subtypes among individuals with darker skin phototypes. So we see a higher percentage of patients of African, Hispanic, or Asian descent with acral lentiginous melanoma. A large number of cases are diagnosed at an advanced stage. Some of the reasons for this is that there is a difficulty in distinguishing from benign lesions. So when they're very early, it may look like a melanocytic nevus or a mole versus a melanoma. And so it may be difficult to distinguish between these lesions, which we'll discuss how we do that. Of course, in our case, the presentation was so late that, you know, it's very unlikely to be anything else other than a melanoma. There has been some reports that these lesions are not biopsied immediately because of increased morbidity associated with procedures at acral sites. So there is an elevated threshold for these biopsies. This is a no-no. We don't want these patients presenting so late. So a third of cases are misdiagnosed initially, which leads to a substantial delay in treatment, which is what happened in the case that we previously discussed. So what are the clinical features of these acral lentiginous melanomas? As I said, these may occur on the soles, the palms, can happen on the digits, and beneath the nail beds. What you'll see is oftentimes black or a variegated brown. So you can have from very light brown to very dark brown areas. And they can also be multicolored, as we saw in our case. Usually they'll have an irregular shape and they can present as a macule. So they may be flat. They can present as a patch. They may be raised. They may have papules or nodules, specifically in these acral lesions that start to ulcerate, they can form nodules within the lesion. Sometimes, or more rarely, you can have an amelanotic acral lentiginous melanoma. These can be pink, reddish, or even flesh colored, and these have commonly been mistaken for plantar warts. It's quite common that when they present to us late, ulceration may be seen. And one of the features of these acral lentiginous melanomas involving the nail apparatus is that they may present with periungual pigmentation. And this is known as the Hutchinson sign. So what you'll see is that you have a longitudinal band of dark brown to black pigment, but there is periungual extension of the brown to black pigmentation onto the proximal nail fold. And this can occur on the lateral nail folds as well. And that is known as the Hutchinson sign. And that really increases your suspicion for a melanoma versus just a benign melanonychia. So just to show us some examples of what our acral lentiginous melanomas can look like, these photos are taken from Visual DX, and they may have multiple different presentations. So this is a patient in a lighter skin phototype with irregular patch. So we say that this has irregular pigment on it. It has some very black areas, some very light brown areas, and you can see that the nail is involved as well. Here on the second digit, you have a brown to black patch. And, you know, of course, we're going to talk later about how dermoscopy can help us when we look closely at these lesions. Again, a lesion on the heel, excuse me, that has some ulceration already forming. So you can see that this lesion has likely been there for quite some time, and the patient is now developing areas of ulceration. Quite commonly in our setting, we see patients that have acral melanosis. So this is common in patients with skin of color, for you to have these brown macules or patches on the plantar aspects of the soles or even the palms. But here you can see that we have a very black patch that stands out from the acral melanosis. Which, you know, has very dark areas, has some light areas, but looks different. And so should alert the clinician that this area needs a biopsy. So how can dermoscopy help? This is a dermatoscope that most of our dermatologists have and utilize in clinical practice. It's a tool that we use to help us distinguish these melanocytic lesions. And so what does it really do for us? So it helps us to more precisely localize the pigment. And on the next slide, I'll show you a photo of what I'm talking about. So the location of pigment in relationship to the furrows and ridges on an acral surface can help in distinguishing benign nevi from a melanoma. And this is when you're dealing with small lesions, not in the case of what was presented. But in the next slide, I'll show you what I'm talking about. So dermoscopy has been shown to significantly improve the observer's diagnostic accuracy when we're evaluating these acral melanocytic lesions. There's numerous specific dermoscopic patterns that have been defined for nevi and melanoma located on these acral sites. So in benign melanocytic tumors, the location of the pigment tends to favor the crystal limitans, and this corresponds to the furrows of the skin. Whereas in melanoma, the malignant melanocytes tend to cluster around the crista intermedia, which in turn often results in pigment located on the ridges. So what does all of this mean? So here we have the clinical photos in A and C. In picture A, this is actually a acral melanoma. So what we're seeing, these are our dermoscopic views in picture B and D. And what we're seeing here is a parallel ridge pattern on dermoscopy. So you can see that the pigment is more defined in the ridges. As I mentioned in picture C, this is a melanocytic nevus. So this is actually a benign lesion. And here the pigment is more in the furrows. So we call this a parallel furrow pattern. So these are our dermatoscopic views of what we would see. And this is how we would determine whether a lesion is, has enough suspicion for a biopsy or whether we think the lesion is benign. But we'll talk more about our threshold for biopsy of these lesions. So as we discussed, the parallel ridge pattern is considered the dermoscopic hallmark of acral lentiginous melanomas. However, it was recently shown that approximately 1/3 of acral melanomas do not display a parallel ridge pattern under dermoscopy. And so this renders, of course, their detection more troublesome, because if we don't see a parallel ridge pattern, how do we decide to biopsy? So Lalos et al. Did a study, and what they were looking at was investigating the diagnostic accuracy of dermoscopic criteria for the diagnosis of acral lentiginous melanoma. They came up with an algorithm that will help us clinically to determine whether we think a lesion is more likely to be a melanoma or more likely to be a benign melanocytic nevus. So they call it the BRAF algorithm. And what they look for is irregular blotches, a parallel ridge pattern, which we discussed, an asymmetry of the structures, and asymmetry of colors. Of course, these are all under dermoscopic examination. If you have any of these features, you would get points, and just only 1 point is required to make the diagnosis of a melanoma or a likely melanoma. If you see a parallel furrow pattern or a fibrillar pattern, these are more reassuring. And so that would be a -1, and you can more lean towards a melanocytic nevus. But as you can see, the threshold for biopsying or sampling these lesions is very low. If you notice any of these top 4 patterns on dermoscopy, then you're more likely to biopsy or sample these lesions. So their conclusion was that this BRAF checklist significantly improves the diagnostic accuracy of dermoscopy for the diagnosis of acral lentiginous melanoma. So when our patient presents to us very late and has these quite large lesions, how do we decide on where to biopsy? Of course, if you have a small lesion, like in one of these photos, an excisional biopsy with a 2 millimeter margin is relatively easy to perform. However, if you have a lesion like what we presented in our case, you know, with it being very large, there's different areas, different colors, different thickness of the lesion. How do you decide? So the NCCN does make some recommendations for biopsies of these large lesions. You want to do a full thickness incisional or punch biopsy. And you want to perform these on the clinically thickest or most atypical portion of these large lesions. And very often it's on the palm or the sole and on the digits. They also recommend multiple scouting biopsies that may help guide the management for these very large lesions. So remember, initially we said that the Breslow's depth is the most important prognostic indicator for these lesions. You want to have an accurate Breslow's depth because this will ensure that you are most appropriately managing these patients, which we'll go on to discuss on how the Breslow's depth helps us to do that. So you have this very large lesion, you decide that you're going to do multiple scouting biopsies. So you'd want to include areas of the thickest portions of the lesion, the darkest portions of the lesion, and of course, if there's any areas of ulceration. Now, they do state that if your suspicion is very low, so let's say you went back to your BRAF algorithm, you saw a parallel furrowed pattern, but your patient came to you saying, you know, doc, this lesion is increasing in size, but clinically your suspicion is very low. They do say that a broad shave biopsy may be adequate for histologic assessment, and these, you know, can confirm for you that your diagnosis is a melanocytic nevi or even a melanoma in situ. But in our setting where patients are presenting to us so late, most times we are doing multiple scouting biopsies because the lesions are quite large. So the point here is that you want to have a very low threshold to biopsy any new or changing pigmented acral lesions, especially in adults, right? So if a person of a darker skin type phototype presents with a persistent lesion on the lower extremity and they tell you that it has been changing in size or changing in color, then an acral lentiginous melanoma should be considered and a biopsy should be performed. How do we manage these patients? The guidelines are quite clear for us. And as I mentioned, the Breslow's depth is what guides our management. So here we can see whether, you know, we have in situ disease, whether a lesion is less than 1 millimeter, 1 to 2 millimeters, or greater than 2 millimeters. So our tumor thickness is also known as the Breslow's depth. And based on your depth, that is what your excision margin will look like. So it does tell you, it does show you how to manage these patients surgically. So that would be your next step once your biopsy has been confirmed. Now, in years gone by, we did not have treatment for these patients, especially with their thicker melanomas. So with thin melanomas, they can be cured by excision alone. And as I said, the surgical excision is guided by the initial Breslow's depth. But now we have adjuvant therapy available to these patients that is prolonging their survival. There's immunotherapy, which includes your CTLA-4 inhibitors and your PD-1 inhibitors. And then there's also targeted therapy. So it has been shown that melanomas, all different types, most of them harbor a genetic mutation. In acral lentiginous melanomas, we would expect them to, most of them harbor the c-KIT mutation, whereas in other melanomas, the most common mutation is a BRAF mutation. So when these patients are identified and your diagnosis is confirmed, you would also send the sample for genetic testing to see if the samples harbor one of these genetic mutations, because treatment can be targeted at the genetic mutation. So let's go back to our case quickly. As we mentioned before, the diagnosis was acral lentiginous melanoma with a Breslow's depth of at least 1.7 millimeters and ulceration was present. So when we see these patients, what do we do? How do we proceed from here now that we've confirmed our diagnosis? Well, of course, we want to stage our patient. And of course, the NCCN guidelines breaks it down nicely for us on how we stage these patients. First, we would determine their TNM classification. So for our patient, he had a thickness of 0.17 millimeters with ulceration. So this puts him at T2B. We then go on to our N classification, which is the lymph node status. And we had mentioned that he did have inguinal lymphadenopathy. So he did have clinical detected nodes, at least one, which puts him at N1B. And at the time when we saw him, he did not have any evidence of distant metastases, so he would be M0. Overall, taking this into consideration, this patient is a stage 3 at diagnosis. They make life so easy for us. They break it down on how to manage every stage of these patients. So a stage 3 patient with clinically positive nodes, first thing you'd want to do is confirm that the nodes are involved by doing a core needle biopsy or fine needle aspiration. If not feasible, then you can do an incisional or excisional biopsies of one of these involved or clinically palpable lymph nodes. Also, these patients require imaging at baseline, and this is to evaluate any specific signs or symptoms of metastases. So the usual way of imaging is a PET CT or CT chest, abdomen, pelvis in our setting with brain MRI, since PET CT is not readily available to us. Of course, you would want to send for your genetic testing, and through one of our partners, we do offer this free of cost to our patients. So as I mentioned before, BRAF is the most common genetic mutation in non-acral melanomas, but they can also be tested for the KIT mutation, which would be more common in the acral melanomas. Once this has been done, you would want to send your patient for wide local excision. As we discussed, it's guided by the Breslow's depth. So in our case, our patient was referred to plastic surgery, and a discussion was had. Now, when we see these acral melanomas, of course, with a Breslow's depth of at least 1.7 millimeter, this patient would require a 2 centimeter wide local excision. On the acral surface, this is hard to achieve, of course, and so these patients likely go on to have amputations. So this is why it's important for us to establish these diagnoses early on. Just to point out, as I had mentioned, there is adjuvant therapy available, which does help or prolong the survival of the patients. As I mentioned, we have nivolumab and pembrolizumab, which are, are PD-1 inhibitors, and patients do quite well on these medications. They are available to us here in Jamaica at a cost, of course. And then, of course, we do have targeted therapy if your patients do harbor a genetic mutation. Radiation is also an option for them, especially the nodal basins. And of course, observation is key in these patients. They will need close clinical follow-up. The guidelines do recommend that they have follow-up every 3 months for a full full body skin examination and examination of their lymph nodes. We know that melanomas have a high metastatic potential, and so close clinical follow-up is very, very important in these patients. And so that our patient went on to have surgery and of course has been lost to follow-up, which unfortunately is, you know, most of the patients we see, they don't come back because there are some barriers to adjuvant therapy, the most being, or the most common being the cost of these treatments. So why do we have these barriers? And I'll just wrap up by talking about this case report that was published in 2015 in the British Medical Journal, because what we want to identify is what are these barriers that are having these patients present so late to us and therefore having a worse prognosis. So this was called Ramifications of Poor Medical Education and Screening in Minority Populations. And this was a case of an extensive acral melanoma. The case was quite similar to our case that I had presented. So what they found was that in minorities, there is poor access to care and screening services. These are large barriers for our patients with low socioeconomic status. Another factor is that healthcare practices clash with societal beliefs. We see this all the time in our cutaneous oncology clinic. Patients come and you will say to them, you know, you have a skin cancer, and they refuse to believe. First of all, they don't think that skin cancers can occur in patients with skin of color. They think that it is a white man disease. And second of all, when you mention to them that they may have to have amputation, it's a no from there. They will not come for follow-up, and they, you know, they don't believe that the diagnosis is accurate, and so therefore they don't believe the management necessary. So patient education regarding their disease and its possible progression and the available treatment options is an important part of your management process. You want to make sure that these patients understand their diagnosis and what is available to them. This it's because another study also showed that the low socioeconomic patients, you know, they generally know very little about their own medical condition. They tend to have a high school education or less. And so proper explanation and having the patient understand will help you to have a more favorable outcome. This case report also mentioned that there is a lack of ethnically diverse physicians, which contributes to low cultural competency during interaction with these patients from minorities, resulting in poor communication and low patient satisfaction. I don't find that that is one of the barriers in our setting, because we know, or our doctors should know, I mean, that, you know, skin cancers, especially acral melanomas, can occur in patients of skin of color. So we just need to make it clear to the patients that this can occur. Some of the other factors they found was language proficiency, insurance availability, time away from work, and low income combined with out-of-pocket expenses. And of these, insurance availability is likely the main barrier. As I mentioned, the adjuvant therapies, they are very expensive. And so if patients do not have health insurance, it is very hard for them to afford these medications. So in conclusion, what I want to get across is that early stage melanomas are often curable by surgical excision alone. So we need to be able to recognize these lesions, make the diagnosis, and send for the appropriate management early. Biopsy, biopsy, biopsy. If you're not comfortable doing the biopsy, send it to one of us. We're happy to facilitate these patients in our cutaneous oncology clinic. Refer, so appropriately refer these patients. If you're unsure, refer the patient, let them have a full clinical examination, you know, send them to a dermatologist that can perform dermoscopy, and so that appropriate measures can be taken to identify these melanocytic lesions. As we have seen, a multidisciplinary approach to each case is vital for best patient outcome. We, in our cutaneous oncology clinic, manage these patients concurrently, usually with our plastic surgeons and our hematologists if they need adjuvant therapy. And the most important point is access to care and early intervention are primary tools for detecting these early melanomas, thus preventing advanced disease and decreasing mortality. Let's not forget our famous Bob Marley, who died from acral lentiginous melanoma. And so we just need to spread awareness that it can occur in skin of color, and we need to pick these up earlier and make our diagnosis and manage these patients appropriately. Thank you very much. These are my references, and I'll be happy to take any questions.
Thank you very much, Stephanie. That was fantastic. A very good presentation, very enlightening. And we're happy to have you as a skin oncologist. We do have 2 questions. You answered one already. what did Bob Marley have? So that was already answered. The other question was, what's the principal cause of melanomas, acral lentiginous melanomas, and is there anything that we can avoid?
Sorry, what was that? The cause of
Yeah.
Okay, so great question. And we know that there is a role of UV damage in other types of melanomas. So especially in our superficial spreading melanomas, melanomas on the head and neck, there is a UV component. And that is usually seen in our patients with lighter skin phototypes, very uncommon in our setting. Acral melanomas more have a genetic predisposition, and we don't exactly know why some people get them and some people don't. As I said, genetics does play a role, but UV light per se does not play a role in these acral melanomas.
Thank you very much. Catania Clark says, great presentation, Dr. Smith-Matthews. Could you tell us the best way for a doctor in private practice to refer a patient to the Cutaneous Oncology Clinic for further evaluation and management?
Sure. So our Cutaneous Oncology Clinic is on a Wednesday afternoon at UWI. I'm happy for anybody to reach out to me if you have any issues or if you have these patients that you would like to refer. All you need to do is send send a patient with a referral form to UWI. And you can address it to me, you can address it to anyone in the skin team, in the dermatology team at UWI, and we will register these patients and we will see them, and we will of course liaise with you, let you know what our thoughts are, you know, what our management plan is, and we'll be happy to see these patients for you. Send them our way and we will manage them accordingly.
Great, fantastic. We have another question here. True, false, melanomas do not occur in skin of color patients. This was in the pre-test. What is the answer? I thought the answer was false, but it is marked incorrectly in the pre-test.
Hi, Dr. James. Thank you for your question. So melanomas do occur in skin of color patients. That must have just been an error in the answers.
Okay, great. Thank you. Waiting for any other questions. You seem to have answered all of our questions.
All right, great.
Let me see. There's one coming up here. Great presentation. Has follow-up with such patients been impacted during the pandemic?
So we find that follow-up in general with these patients is not great. As I mentioned before, there's a lot of barriers, especially in what patients believe, and that they don't believe they have a diagnosis of skin cancer. So we get a lot of patients who are lost to follow-up. Our patients that do follow up with us, I don't think that they've been affected by the pandemic. Our clinics were never closed, they were cut down, but definitely for our cutaneous oncology patients, or even our complex derm patients, we always try to facilitate them in clinic, and they are pretty good. The ones who do follow up, they are pretty good about coming to their clinic visits. So no, in terms of the pandemic, I don't think that it has affected our patients.
Wonderful, wonderful. Okay, great. Well, not seeing any other questions. Any last questions? Anybody else with a question? Like I say, a great presentation needs very little question and answer. All right, everybody's congratulating you on a great presentation. Thank you so much.
Thank you. Thank you so much for having me.
Thank you. All right. At this time, we are going to go into our sponsors' presentations, and we have a presentation from Arista Pharma Limited. Okay, and we're going to be doing several pet presentations, each of them 5 minutes apiece. So go ahead, Arista Pharma, and do your presentation for us.
Good morning, everyone. Is everyone hearing me clearly?
Yes, loud and clear.
Okay, good morning, everyone. I am Shanice Henry from the Arista Pharma and the R.A. Williams team. And this morning, we will be going on a journey exploring the possibility of a better patient treatment. Is everyone seeing my screen?
Yes, seeing it very clearly.
Okay, thank you for that. Before I do so, I would like to introduce to you who Arista Pharma is and why you should choose Arista Pharma's products. Arista Pharma is one of the top 10 pharmaceutical companies in Bangladesh. The company was founded in 1986 with the honest promise to provide quality medicines at affordable prices. Currently, Arista Pharma exports its products to 34 countries of 5 continents. They have a wide range of products of over 200 brands in 400 doses, as well as a staff complement of over 6,000 employees island-wide. Now, Arista Pharma's company motto is quality the unit we count. We believe quality is a journey and not a goal. Therefore, our efforts to improve quality never ends as we continue to set higher standards to better serve your patients. Now, mask-associated dry eyes is a phenomenon that came into existence since the COVID-19 pandemic. Individuals who wore face masks for a prolonged period of time were found to have an increase in dry eye symptoms. So what exactly is this mask-associated dry eyes? It is really dry eyes as a result of wearing the face mask for a prolonged period of time. What is really happening is the air from the mouth and the nose goes up into the eyes and there's evaporation of the tear film. If you wear glasses, this is something that you'll notice as well. Your glasses tend to fog up if the mask is not fitted properly. It is the same with mask-associated dry eyes. Now, groups that are more at risk are persons that wear the mask for the entire day with minimum break. For example, the clinic staff. Now, ocular surface irritation or inflammation is experienced by patients. Now, recommendation is, of course, the use of a lubricant eye drop. Now, for a more graphic representation of what is happening in the eyes, with discontinued air blowing into the eyes, with the evaporation of the tear film, pockets are formed, and underneath these pockets in the tear film are damaged epithelial cells. We are proposing Cystear as your lubricant of choice, which is Arista Pharma's polyethylene glycol and propylene glycol lubricant eye drops for the treatment of mask-associated dry eyes or dry eyes. How does Cystear help with mask-associated dry eyes? Cystear consists of propylene glycol and polyethylene glycol that provides excellent lubricity across the eyes. The polymers plugs these pockets that are formed and therefore promotes healing of these damaged epithelial cells. The borate in the formulation binds these two polymers together, thereby promoting healing and allowing for longer lasting effects. In these pockets, the epithelial cells begin to recover at a faster rate. With this formulation of Cystear, there is increased lubricity along with healing, which results in the relief of dry eye symptoms. For the patients, the eyes are now feeling more cool, soothing, and the experience is now more tolerable. With all of that being said, when it comes to mask-associated dry eyes or dry eyes on a whole, Cystear should be your lubricant of choice. It is available over the counter and in the pharmacies island-wide. Another phenomenon that was found since the COVID-19 pandemic is the exacerbation of acne as a result of wearing face masks, as Dr. Carrie Clark had mentioned in her presentation earlier this morning. Now, this is Pamela, meet Pamela. Now, when Pamela removes her mask at the end of the day, or when she removes her mask after wearing it for a prolonged period, she notices acne at the area of her face where her face mask was. So what is really happening is there's a buildup of bacteria in the pores of her skin. Dead cells become trapped in the hair follicles along with the bacteria. We are proposing Clinex as a form of treatment for this exacerbation of acne. Clinex is a topical antibiotic comprised of clindamycin 1% solution. Due to its mechanism of action, Clinex potently inhibits inflammation, thereby reducing the number of bacteria as well that causes this acne. It has anti-inflammatory effects that makes the pimples less red and swollen. Also to note, Kleenex is a water-based lotion, therefore there is no itching or burning of the skin. Fusidate H is another product by Arista Pharma. It is formulated by fusidic acid 2% and hydrocortisone 1%. The Fusidate H is ideal for eczema and dermatitis with secondary bacterial infections such as atopic eczema. This product works by inhibiting the growth of bacteria and reducing redness, swelling, itchiness at the site of infection. Fusidate H is also available in all pharmacies island-wide. Now, Arista Pharma has two types of inhalers, a bronchodilator, which is Sulflo, and or reliever, which is Sulflo, and also a preventer, which is the Aroflow. The Sulflo consists of salbutamol 100 micrograms per puff, and even after the NHF subsidy, Sulflo costs less than $300 to the patients. The preventer, which is Aroflow, is available in two strengths, 250 and 125. After the NHF subsidy, Aroflow was found to be the most affordable on the market. Other Arista Pharma's products. Arista Pharma's ophthalmic line consists of Staphen and Olpidine, which are antihistamine eye drops indicated for allergic conjunctivitis. Aristabet N is a combination of steroid and antibiotic, which is betamethasone and neomycin, and can be used in the eyes, ears, or nose. Mycon oral gel is useful for treating infections of the mouth, such as thrush. And also to note, it can be used in babies as young as 4 months old. And last but not least, Arista Pharma's nasal spray indicated for patients with allergic rhinitis. The name is Flutica. The active ingredient is fluticasone furoate. This nasal spray has a very gentle mist, therefore it is well tolerated by children as young as 2 years old. Flutica is available island-wide in the pharmacies as well, and costs almost less than 40% comparing to the brand. These are my references, and this is the end of my presentation. Thank you for listening, and I hope you all continue to enjoy this very informative conference. Thank you.
Thank you to Arista Pharma for their sponsorship and for their presentation. We now have a presentation from H2K Canada.
Tafari, do you want to go ahead with the video?
Yes, we're queuing up that right now.
Okay, thank you.
You're welcome.
Good day, everyone.
Good day, this is Health 2000 Canada, otherwise known as H2K. We proudly serve the Caribbean since 1999. Borototal Neem Cream, an Ayurvedic antiseptic cream that heals, soothes, moisturizes, making it the perfect companion, the power-packed herbal alternative for wound healing and skin infections. Borototal Neem Cream reduces topical pain, calms minor skin inflammation, fights minor skin infections, and promotes skin healing. The key ingredients in Borototal are zinc. Zinc is incredibly good for your skin as it heals and rejuvenates. Sesame Seed Oil. Sesame Seed Oil treats inflamed, irritated, and damaged skin due to its high antioxidant and antibacterial properties. This oil penetrates deep into the derma, fighting bacteria, and leaves your skin vibrant and detoxified. Licorice root extract. This has powerful anti-aging and skin-soothing properties. It regulates oil production and can naturally combat hyperpigmentation to stimulate wound contraction for a better healing outcome. It is a great choice to treat rosacea and eczema. Aloe Vera. This has anti-inflammatory and cooling properties, excellent for sunburned skin. Aloe Vera provides a protective layer to the skin, helping to speed healing and retain moisture. It contains substances like glycerins and polysaccharides that stimulate the growth of new cells, while glycoproteins reduce inflammation and redness, great for acne scars and stretch marks. Ashoka. Ashoka has anti-inflammatory properties and is a natural astringent, hence skin cleanser. It reduces irritation and burning sensations in the skin. Neem. Neem provides a wide spectrum of antibacterial action. It helps to protect the skin from free radical damage. Neem contains high levels of important fatty acids and vitamin E to quickly penetrate the outer layers of skin, making it extremely effective in healing dry and damaged skin. Neem is antimicrobial, effective for treating acne, and is non-comedogenic. Boretotal neem cream is locally recognized and effective for the diabetic foot, that thin, dry, papery skin that is prone to ulcers forming. Boretotal is effective on cuts and scratches, nappy rash, dry cracked skin, dry cracked nipples, maskne, blisters and burns, minor sunburn, insect bites, and much more. You can apply Boretotal 2 to 3 times per day over the affected area after thoroughly washing and drying. H2K Naturella 5-in-1 cream, formerly known as Brown and Beautiful, contains licorice root extract, niacinamide, lactic acid, and ursa leaf extract. Use daily for youthful looking skin. Stay flawless without bleaching with H2K Naturella. H2K Silvacant Silver Sulfadiazine Cream provides fast relief for 2nd and 3rd degree burns and prevents infection of burnt surfaces and chronic ulcers. Let's talk H2K prescription medication. Today's focus will be on dermatology. H2K azithromycin 500 mg high clinical success in hidradenitis suppurativa, pyoderma, furunculosis, impetigo, cellulitis, acne, and confluent and reticulated papillomatosis. Did you know we also offer SCASI 200 oral azithromycin suspension? It has a menthol minty flavor, enhancing compliance in children and the elderly. H2K ciprofloxacin 500 mg broad spectrum antibiotic for quick recovery at a lower cost for conditions such as Pseudomonas infections and some infected leg ulcers. H2K amoxiclav 625 mg and 1000 mg stop bacterial infections such as bolus, impetigo, leg ulcers, any infected inflammatory skin disorders right in its tracks. H2K fluconazole 150 mg used to treat a variety of fungal infections such as dermatophyte fungitinea and pityriasis versicolor, as well as yeast infections. H2K fluconazole can be prescribed with antibiotics that may cause a yeast infection. H2K acyclovir 5% cream, fast-acting antiviral medication for cold sores. H2K ketos, ketoconazole 2% cream, antifungal, effective for athlete's foot, jock itch, ringworm, certain kinds of dandruff, as well as pityriasis versicolor. H2K betad 0.05% betamethasone dipropionate cream, beaten itch or eczema. Get quick relief and treat it the right way with betad anti-allergic topical cream. H2K clotrimazole 1% cream treats skin infections such as athlete's foot, jock itch, ringworm, cutaneous candidiasis, and tinea versicolor. H2K Escaderm, a powerhouse combination of betamethasone dipropionate, clotrimazole, and gentamicin sulfate for the 3-in-1 effect. H2K ketoconazole 2% anti-dandruff shampoo, the right choice for dandruff and seborrheic dermatitis. It is also helpful in the treatment of tinea capitis and tinea versicolor. Please support us by writing H2K before the drug name on your prescription. All our products are available in pharmacies island-wide. Thank you, everyone. Continue to enjoy the webinar and have a wonderful week ahead.
Thank you very much to H2K.
You're welcome.
All right. And now we have a presentation from Medimpex, Jamaica.
Good day, everyone. My name is Paulette Bedward, Medical Representative here at Medimpex Jamaica Limited. Today, I will be highlighting a few of our dermatology products within our portfolio. Firstly, let's look at Clobigen Mk. Clobigen Mk is our triple ingredient combination product. The name is an acronym for the 3 ingredients it contains. It contains clotrimazole, betamethasone, and gentamicin. It is indicated for eczematic dermatitis, solar dermatitis, folliculitis, paronychia, dihydrosis, intertrigo, impetigo. Clobigen Mk should be thinly applied to the affected area of the skin once or twice daily, in the morning or in the evening, or both. For tinea pedis, should be used for a maximum of 4 weeks, while for tinea curis and corporis, maximum of 2 weeks. Long-term corticosteroid treatment should always be avoided. Price here at Medimpex, very competitive, $675 per tube. Retail cost to the patient, less than about $1,000, even with, or roughly about $1,000, even with 50% markup. A few of our other products are mometasone, which is our medium-strength corticosteroid, indicated for the relief of the inflammatory and pruritic manifestations of corticosteroid-responsive dermatosis, such as eczema and contact dermatitis, redness, swelling, itchiness in some conditions. We also have ketoconazole MK, which is an antifungal cream indicated for the treatment of dermatophyte infections of the skin, cutaneous candidiasis, pityriasis versicolor, and seborrheic dermatitis. We also have clobetasol MK, which is a very strong corticosteroid, which is used in short-term courses to reduce swelling, redness, bumps, and scaly crusting skin that has not responded to steroid creams in skin problems such as small patches of psoriasis, eczema, lichen planus, and discoid lupus erythematosus. We also have ketotifen, liquid formulation, oral formulation. And ketotifen possesses a powerful and sustained non-competitive histamine blocking property. It is used for the treatment of allergic conditions such as itching and rashes. Dose, 5 ml twice daily. Up next, I want to highlight our MediScrub, which is a broad-spectrum antiseptic, particularly effective against dermatophytic bacteria and fungi. It is used for pre-surgical hand disinfection, incision site skin antisepsis, and decontamination of surgical instruments. Priced here at Medimpex, $7,540 for the 5-liter bottle, as shown in the image. Up next, I would like to highlight our Curiosin, which is no strange product to the dermatology line here at Medimpex. Curiosin is a wound care preparation designed for quality wound healing. It is a clear, non-irritant, highly biocompatible product supplied as a gel for the management of various. Curiosin, it works by providing a moist environment necessary to facilitate physiological wound healing. The viscoelastic matrix formed facilitates granulation and epithelialization. It protects the cells against free radicals, resulting in reduced tissue inflammation and controls wound pain. Curiocin is used for the management of various types of wounds, such as venous leg ulcers, diabetic foot, arterial leg ulcer, and decubitus ulcers. It is also used for the management of minor injuries, such as household injuries, lacerations, and first and second degree burns. How to use? Complete debridement if needed by gently rinsing with 3% hydrogen peroxide or saline. Apply Curiocin as a continuous thin layer to the entire compromised skin area. It's recommended for once daily use. NHF now covers Curiocin gel, and the subsidy is $843 per tube. The patient pays the balance of $1,100. Also, point to note that it's covered under diabetes and venous disorders. For moderate conditions, 1 tube per month is allocated. For severe conditions, 2 tubes per month is allocated. Just a reminder that unfortunately, time does not heal all wounds, so we need to close the wound with Curiocin. Thank you for your attention and have a wonderful rest of the afternoon.
Thank you, Madam Pex, for that presentation. We will be resuming in our second session at 11:30. We have 2 more presentations by our sponsors. The next is from the Carrie Group Limited, Janssen Pharmaceuticals. Safari, do we have a presentation from the Carrie Group Limited?
No, they should be. Here they are. They're sharing their screen.
Yes, hello, good morning. Are you hearing me?
Hearing you loud and clear.
Right, are you seeing my screen?
Yes, we are.
Okay, thank you so much. Thank you, Dr. Swaby. As you mentioned, my name is Karen Foote, and I'm from Janssen Pharmaceutical, representing Janssen as well as Carrie today. And what I wanted to do, since this is a dermatology meeting, is just highlight one of our popular products with you for acne, which Dr. Clark presented on earlier today. And she did mention retin-A, but she said tretinoid. So that is the active ingredients for retin-A. And we have it in 3 presentations in Jamaica, all creams. And we have 0.025%, 0.05%, as well as 0.1%. And all are for the treatment of acne. How retin-A works is by causing a rapid turnover of the cells in the skin, and therefore bringing to the surface of the skin the bacteria or irritants that are trapped in the pores to get rid of it. It also regulates the natural occurring oils in the skin and therefore preventing future breakouts. It also has an anti-inflammatory property that will treat active acne as well to get rid of those pustules with the acne. So just to highlight that it's how it is used, it's once daily, only at night, and it's just a small teardrop that application that the patients need. So for the 0.05, that is our most popular presentations because for normal skin. However, for sensitive skin, we have the 0.025, and for mixed skin, we have the 0.1%, or also for severe acne, you can use the 0.1%. What I would just highlight as well is that although retin-A is an excellent choice for the treatment of acne, not only does it have efficacy in treating acne, but for those persons with scarring, it will also reduce the appearance of the scars. Also, in terms of the spots, it also helps to reduce the appearance of the spots. Therefore, you don't have to use an additional agent like a lightening cream when you're using Retin-A. As Dr. Clark mentioned, you can combine it with your antibacterials or other creams once you separate the application. So normally you should, as Dr. Clark mentioned, cleanse the face with a mild soap, dry gently, do not rub, and ideally you should wait approximately 30 minutes before applying Retin-A. And as I said before, you just apply a pea-size amount and do not rub it in aggressively because that can cause irritation. And usually the treatment period is 10 to 12 weeks. However, with although it is used once per day, maintenance, you can use it less, approximately 2 or 3 times a week, depending on what the response of the patient. So, and it's available through CareMed, and it's at a cost of $2,800. All presentations are approximately the same cost. So just wanted to highlight our Retin-A to you and mention to you, as I said, that we have the 3 presentations all available. And although Retin-A is FDA approved for acne, it's also approved for reducing lines in wrinkles, also improving the appearance of the skin. So it's an excellent choice for your patient with acne. And that's it. I don't know if anyone has any questions, but that's it for me.
Thank you so much. That was short, sweet, and very comprehensive. We are going to go on to our presentation from Indus, and I'm going to turn over to Dr. Aldith Buckland now.
Good morning, doctor.
Morning, good to have you. Thank you so much for your sponsorship this morning.
Thank you very much, doctor. Can I go ahead and share my screen?
Go right ahead.
Thank you very much. This is Daya from Indus Life Sciences. I thank you very much for Agpj for this opportunity to be on board to sponsor this meeting. And greetings to all the presenters as well as the panelists for today's meeting. And you are able to see my screen?
Yes, seeing it.
Yeah,
we see your desktop.
Yes, that's it. So I'm just trying to look at the slide. Yeah, here it is. From Indus Life Sciences, I would like to just refresh a couple of our brands. And this is the first time we are coming on board for a dermatology conference. So we are very excited. And just to share a couple of our brands that we have in Indus Life Sciences. One is a drug for allergy, especially for urticaria, angioedema, and other conditions. I'm pretty sure this is a good scope with the dermatologist from Indus Life Sciences. We have the 2nd generation antihistamine. Of course, the 1st generation antihistamines are really good too, but they have their limitations of side effects like blurred vision, constipation, dry mouth, and stuff like that. The 2nd generation antihistamines are devoid of all those side effects, and they also found to be very popular across the globe. And we have the 2nd generation, which is fexofenadine from Indus Life Sciences. And we know it is widely used in conditions like, especially by dermatologists in case of urticaria, like, itchy, skin irritations like that. And of course, it is also recommended for allergic rhinitis and even people who are wearing masks for a long time, because of the pandemic, who are having cough or allergy because of the mask. Also, it could be considered. We have the brand name as Fexil. How we coined the brand name is very interesting. It is just to fix the allergy, fix it. That means allergy with Fexil. So very short and sweet brand name, Fexil, to fix it, fix the allergy. We have in 120 and 180 milligram. It's available as, and it's once a day, we all know. And the 120 milligram is over the counter, no need for prescription. But 180 milligram is definitely needs a prescription. So we have in both the strength, and we have a benefit on price. No, I'm not bashing any competitor brands. They're all good, but just to give an idea about the pricing, we have the best priced is our Fexil. A pack of 30 pills, that what you see here, the 120 milligram is around $1,050, and the 180 milligram is $1,650 for 30 pills. If you break down per tablet, it respectively $35 and $55 per tablet. And we all know it's once a day, so it's very affordable for that cost of $55 and $35 respectively once a day, which I could even jokingly normally mention it is cheaper than a peanut pack. Of course, it can be used for peanut allergy also. That's our Fexil from Indus Life Sciences, Fexofenone, available in all pharmacies across the island. Fix your allergy with Fexil, this is the bioequivalence study report, which has even confirmed the efficacy of Fexil is as efficacious as the brand itself. We know the innovator brand. Fexil is as effective as the innovator brand with the bioequivalence study. And we have another interesting drug for treatment of neuropathic pain, and especially conditions like herpetic neuralgia. We have our medication, which is basically pregabalin. Of course, the intention here is to reduce the pain and bring back the smile in the patient's face. Of course, it is also recommended in other indications like diabetic peripheral neuropathy, fibromyalgia, and also partial onset of seizures and general anxiety disorders. These are some of the indications where the pregabalin is being used or recommended by dermatologists and other specialists also. And quite good number of studies are available, especially in case of herpetic neuralgia. We know it is found to be very effective in comparison to placebos, where the double-blind studies has been done, where it has been pregabalin is very effective in relieving pain of acute herpetic neuralgia. This is one of the study that was reported in Annals of Neurosciences, and also there was another study which was around 2003, which was reported in Neurology, published in Neurology, where pregabalin for treatment of post-therapeutic neuralgia is found to be more effective in comparison with placebo. Basically, these studies are done against placebo. Here, around 173 patients has been included in this study, and the study also clearly indicated pregabalin is safe, efficacious in relieving pain in case of post-therapeutic neuralgia than that of placebo. And we have as a pregabalin from Indus as a neurobalin. We coined the brand name neurobalin just to communicate neuropathic pain pregabalin neurobalin. That's how we coined the brand name. Neurobalin is neuropathic pain pregabalin. Neurobalin. We have 75 and 150 milligram. Just to give an idea, of course, we are not the first brand of pregabalin in Caribbean. Before that, the innovator brand was there. And I'm not bashing against the innovator brand. It's still very efficacious brand, very popular also. But where the challenge, what we were encountering when we were about to introduce this product was that the cost of this medication, pregabalin, was very expensive. Some doctors even shared that even when the patients are prescribed this drug based on the merits of this molecule pregabalin, patients are shying away filling the prescription as the price was exorbitant. So one thing we decided is that we should definitely break the barrier of pricing, as because many a times we forget. Normally when the patient presents with the pain, only the intention is to reduce the physical pain they encounter because of the condition they undergo. But sometimes we neglect another pain, which is a monetary pain. So that is where we decided we should introduce this drug, not only for the physical pain, but we also should eliminate the monetary pain the patient suffers. That's where, if you could see, the cost of treatment of neurobalin is the most affordable in Caribbean. Just to give an idea, doctor, the 75 milligram, a pack of 30 pills, neurobalin is $2,850. You can look at the cost of other brands for same 30 pills, how much they are. We have 150 milligram, which is just $3,250, whereas the other brands of pregabalin is way expensive than neurobalin. And another good news is that neurobalin 150 milligram is 100% subsidized by NHF. When the patient has NHF card and they have your prescription for neurobalin, they go and fill in the pharmacies, and the NHF subsidizes the 100% cost of neurobalin if it is 150. And for 75 milligrams, literally 85% of the cost of neurobalin is subsidized. I could say the patient maximum may spend around $350 to $400 per month if it is neurobalin. So that's the benefit, and you not worry about the efficacy, as because it is affordable. Please don't think the brand is not efficacious. It is as efficacious as the brand itself, Neurobalin. We have the bioequivalent study, which has confirmed the efficacy of Neurobalin as good as the brand of pregabalin. And just to give an idea, I don't know whether you're able to properly see. It is not much clear, but I can help to read this. This is the actually receipt copy where a patient has filled in Neurobalin 150 milligram. The patient has bought 30 pills, and the actual cost was $3,394.90. And this was not long ago, just in the month of May 2021. And the NHF subsidy was $3,225.15. So you could now definitely will agree with me. The patient will be spending just $100 for the 150 milligram for 30 pills. So which is definitely a big saving, especially during the pandemic, where everybody's squeezing to look for opportunity to save money. So, and we have the patient benefit coupon. Don't worry about the date on it. We have long expiry coupons, which can additionally give some free pills to your patients. So doctors who require, want to pass the benefit, please communicate to our med reps when they meet you. Ask for this coupon. Whenever you prescribe Neurobalin, along with the NHF subsidy, they'll get free pills from the pharmacies. For every 30 pills, they get 10 free. If the patient fills in 60 pills, that is for 2 months, I could say, they'll get 3 weeks of the drug completely free, apart from the NHF subsidy. So that's our Neurobalin. So, and we have another drug which I just like to refresh. That's our pain Rub Capsicum, ideal for any type of pain: joint pain, back pain, shoulder pain, knee pain, wrist pain, arthritis pain, which is we call it a SWAT team, as because it has 3 active ingredients. They work synergistically. One is the capsaicin, which we all know, extract of pepper, capsicum, that we normally take. And then it has diclofenac, it has methyl salicylate, and these 3 active drugs work in different mechanism to deplete pain. Capsaicin depletes by inhibiting substance P. Diclofenac depletes pain by inhibiting prostaglandin. Methyl salicylate as a counter pain mechanism, as well as it depletes by inhibiting interleukins. So for moderate to severe pain, Capsitop could help to reduce the pain. Is a gentle spread is sufficient. Need not to do aggressive massage. Why I'm specifically saying that, as it has capsaicin, aggressive massage, some patients may encounter burning sensation. Some may like it, some may don't like it. So just for caution, a little spread, gentle spread, 2 to 3 times a day is sufficient to reduce the pain and bring back the smile in patient's face. And this is over-the-counter product, and it's just cost around $800 to $850 in the pharmacies, a 30-gram tube of Capsitop. And another important product which I just want to refresh is our supplement. As we all in pandemic time, we all look for supplements, to boost our immunity. So we have one nice supplement which offers all the vitamins that normally we look for from a supplement. Plus, it also additionally offers protein. When I say protein, the essential amino acids, the 10 of them, right from histidine, arginine, tryptophan, valine, all these essential amino acids makes the protein, and it has all the 10 essential amino acids in active form for immediate protein synthesis. And the indications for this supplement, which we call as amino pep, gives a pep to your step. That's why we call as amino pep. Which is good to, in this stressful time of pandemic, help to cope up with the stress. We all know under stressful conditions, especially frontline warriors like medical doctors, nurses, and paramedics, stress will definitely kill even your appetite too, apart from it causing weakness, fatigue, inability to concentrate on the job, whatever it is. So you can give a little pep to your step with our supplement, which is amino pep, and is good for growing phase. Especially kids do face a lot of challenges in the online classes they are exposed to, and for them also to be more active during the online classes, as well as in at playtime, whatever they do. So it will help them. And convalescence, obviously, it helps to faster recovery during the recovery phase. Those who are especially quarantined at home, they have a lot of challenge to come out of quarantine. For them, this supplement will be a real ideal supplement, as it offers vitamin C, vitamin D3. It also offers zinc, which is 50 milligram elemental zinc. which is ideal to boost the immunity, which we all talk about. Elderly people, obviously, it is very, very important for them as they are more vulnerable during the pandemic. And also AminoPep helps to strengthen the muscles, a condition called as sarcopenia, which is basically softening of muscles as persons get aged, maybe around 60 years, 70 years, 80 years, it affects their mobility because of condition called as sarcopenia. And a supplement which has protein with vitamins and minerals is ideal for them to strengthen the muscles and improve their mobility. So it's ideal for elderly people also. This is actual composition of AminoPep. As you could see, it has all essential amino acids and it has all vitamins, right from vitamin E, B1, B2, B6, B12. It has folic acid, it has calcium, it has vitamin C, it has zinc, vitamin D3, vitamin A, all in one is AminoPep. It's normally recommended 10 ml once or twice. And for kids, 5 ml once or twice. Somebody is seriously sick and recovering, you can step up to 15 ml also. It's chocolatey flavor. It's sweet, but no natural sugar. Can be safely given for diabetes patients also. And those who have a little challenge, how to identify a right supplement, probably this could help you. When you are confused to select a right supplement, please look at this chart and just try to answer them. Look for a supplement which offers all B-complex multivitamins. Probably every brand that you see in the pharmacy may get through. Then look for the amino acids. Probably that's where AminoPep will stand out. And look for zinc on the supplement. Again, AminoPep will stand out. And also look for the chronic illness safety. That is diabetes patients, AminoPep will stand out. And value for money, AminoPep will stand out. If you don't believe me, next chart will help you to understand. I'm again not bashing any brand, is just only giving an idea where AminoPep versus the competitor. If you look at the brands that is popular across Caribbean, Pharmaton TD, Bicozing, Protogem, some of the brands I could say, and you can see which stands tall, AminoPep stands tall. And look at the composition, protein, vitamins, zinc, mineral. Most other only vitamins. Cost, AminoPep, value for the money is around $1,500 to $1,600 for 200 ml, as most other brands more than $2,000. So to conclude, become healthier with right supplement which offers vitamin C, vitamin D3, and vitamin zinc. And my humble request as a medical doctor, you are a frontline warrior, your safety is very important. Please kindly keep one AminoPep at your workplace as well as at your home, and please take at least 5 ml 2 times a day. And doctor, if you need sample, I'm going to put my contact number in the chat. Please call me, or when MedReps comes to your office or to your place to detail you, please ask them. We have plenty of AminoPep samples we can give for you as well as for family members. Thank you very much. Have a nice day.
Thank you very much to Indus Sciences. And we are going to turn over to Aldith Buckland, Dr. Aldith Buckland, for session 2. Not seeing Aldith at this time. Can we get a confirmation that Aldith is on? Donald?
Okay, I am here. That's just on a different wing of the plane. Good afternoon, everyone. It's still morning. It is a pleasure to be part of the Association of General Practitioners Dermatology workshop. We've had an amazing first session, you must agree. And also for the sponsors, we are very happy to have you on board with us as well. And to Indus Life Sciences, we do appreciate that you are able to sponsor this second session. We have 2 amazing pilots on this leg of the flight. The first one is Dr. Donna Graham, and the second one is Dr. Lorena Muir-Green. Both of them are consultants, and they're going to bring their expertise in our deliberations of this workshop. Now, Dr. Graham, she is a consultant dermatologist, and she graduated from the University of the West Indies, Mona, with a BSc in biochemistry and zoology with honors, a Bachelor's of Medicine and Bachelor's of Surgery, and Doctorate of Medicine in Internal Medicine. She went on further to specialize at King's College London, where she gained a master's in clinical dermatology with merit. She enjoys her work at the University Hospital of the West Indies as a consultant dermatologist. She accumulated experience in the management of rheumatology patients while working with Dr. Leculier in Montego Bay. She is a Chief Executive Officer and founder of Revolutionary Healthcare Limited and partner of Jamaica Allergy Clinic. Dr. Graham is also a member of the American College of Physicians, the Caribbean Dermatology Association, and the Dermatology Association of Jamaica, where she previously served as secretary. However, Donna's favorite role is that of a proud mother to her almost 7-year-old son, Sloan. So we do appreciate that she has taken time from her family, I know how precious this is, to present to us on cutaneous manifestations of autoimmune connective tissue disease. Dr. Graham, your turn.
Good morning, Dr. Buckland, and to the entire AGPJ team and sponsors and or participants. Let me just share screen. Oh, 1 second. Are you seeing my slides?
No, I'm not seeing your slides yet.
Not as yet.
Yes.
Yes, we are. Okay. All right, so this morning I'll be presenting on skin manifestations of autoimmune connective tissue disease. As you can imagine, it's a pretty large topic, so I'm going to actually focus on the clinical manifestations and the workup of cutaneous lupus erythematosus, dermatomyositis, and scleroderma. So our first case is that of a 27-year-old female who presents to us with a 1-month history of an itchy tender plaque to the scalp associated with hair loss, and she also admits to having arthralgia. On examination, we saw 2 well-defined indurated erythematous plaques with surrounding hyperpigmentation. There's a follicular prominence that I don't know if you can appreciate nicely here. There is depigmentation with a central atrophy. There's a little erosion on this one that is there. On further examination in the conchal bowl of the ear, you see this beautiful hyperpigmented, slightly erythematous plaques with nice follicular plugging that is there. So what's the diagnosis? With the follicular plugging, that is pathognomic of discoid lupus. So the patient has discoid lupus. Discoid lupus erythematosus can also, it's the most common form of chronic cutaneous lupus erythematosus. It can also affect the mucosa involving the lips, the buccal mucosa, the genital mucosa can also be affected. There is a palmoplantar variant that will present with erythematous scaly plaques on the palms and the soles with central hypopigmentation and peripheral hyperpigmentation, as is shown here. You can have a hyperkeratotic variant where you get lots of thick scales that are adherent to it. Must be careful, have close examination of these patients, as the chronic lesions, especially on sun-exposed skin, can actually form squamous cell carcinomas, as is seen in this photograph here. And dermoscopy is very helpful for us to be able to determine when there is possible changes and for us to biopsy it. We usually monitor the patients to see, check for activity of the discoid lupus based on the amount of erythema and scaling. And the patients may then heal very slowly to have atrophic, hypo and hyperpigmented scars, as is seen in this photograph here. There are other forms of chronic cutaneous lupus. You can get a paniculitis that occurs, which when that occurs, you can get this sunken nature of the subcutaneous tissue and fat, as well as if you have discoid lupus occurring on top of a paniculitis, then that is called lupus profundus. See this erythematous papule or nodule that is right here on the cheek, which can commonly occur especially on the anterior chest and sun-exposed areas, is lupus tumidus. And then there is chilblains lupus, which can occur on the fingertips whenever the patient is cold. You get this very dusky erythematous purplish macules. 20% of patients with SLE will manifest discoid lupus lesions, and 5 to 10% of patients with DLE will have systemic involvement or go on to develop SLE. However, only 1 to 2% of patients with localized DLE progress to SLE. So when the discoid lupus is confined to just the head and neck, then that's considered localized discoid lupus. If it extends, however, onto the torso, so the upper trunk, the upper extremities, and it also is involving head and neck, then it is considered as generalized or widespread lupus erythematosus. The most common place to be affected with discoid lupus is the scalp, and it causes a scarring alopecia. So we have to be very aggressive with the management of these patients. And we have to also advise the patients that this is scarring, and therefore we may not be able to get back the hair growth that is there. Smoking also reduces the effectiveness of antimalarials and other therapies used to treat DLE. So it is extremely important for us to advise the patients to stop smoking and assist them in whatever way we can with smoking cessation. Risk factors for developing SLE is widespread discoid lupus, arthralgias or arthritis, anemia, leukopenia, elevated ESR, positive ANA, and nail involvement. Patients with discoid lupus tend to present with more skin findings and not so much systemic findings. So you may get normal lab results and it's just skin-limited disease. Cutaneous lesions of lupus erythematosus can be divided into lupus-specific skin disease or non-specific skin disease. So we spoke about the chronic cutaneous lupus erythematosus, which is one of the specific skin disease, or another specific skin disease is the acute cutaneous lupus erythematosus, which most commonly presents with malar erythema. So you get this erythema and swelling that occurs on the cheeks with sparing of the nasolabial fold. It also occurs on the tip of the nose. This tends to be very transient, and once the patient is treated, it goes away without any scarring at all, unless there was some other infection, it got infected or something like that. That's the only way you tend to get scarring with that. You can have it generalized, where you get erythematous macules and papules or patches onto the entire body, especially in sun-exposed areas, and it may occur especially on the extensors of the limbs and on the dorsum of the hands. And the thing with this is that it tends to spare over the knuckles. Unlike dermatomyositis, which we will review later that involves the skin of the knuckles. You may also have associated nail fold erythema. And you can have toxic epidermal necrolysis type or like acute cutaneous lupus, where you're getting vesicular bullous reaction, but it tends to be now in just mainly photosensitive in sun exposed areas. So that usually is a clue to suggest that maybe this is not just due to a drug that is causing it. And it usually has a much more insidious onset. Subacute cutaneous lupus, however, tends to present as scaly papules that can then enlarge to form very annular polycyclic plaques with peripheral scaling, and you may even end up with some blisters towards the periphery of these lesions. Tends to occur on the torso of the patient, the upper torso, sun-exposed areas, upper arms. That's where it tends to be involved with these patients. 50% of patients with subacute cutaneous lupus will have SLE. So with the acute cutaneous lupus, majority of those patients are going to have SLE. Whilst with subacute cutaneous lupus, only about 50% will have SLE. Whilst with discoid lupus, only about 5 to 10% will actually have systemic lupus erythematosus. And with discoid lupus, you're going to be left with scarring. So there's going to be some atrophy that is there to the skin. Whilst with subacute cutaneous lupus, there's usually no scarring that is left, but it tends to take a lot longer to resolve. And it may result in, or most often results in, dyspigmentation of the skin. So they may have hypopigmented patches. So they're not atrophic, they're not sunken. Hypopigmented patches or hyperpigmentation may be left behind. Whilst with acute cutaneous lupus, those patients resolve without any scarring at all. 10 to 15% of patients with subacute cutaneous lupus will develop severe SLE, and this is when the patient has nephritis or CNS disease like a lupus erythematosus and systemic vasculitis. Subacute cutaneous lupus can overlap with other autoimmune diseases, including Sjogren's syndrome, rheumatoid arthritis, and Hashimoto's thyroiditis. There is a strong association with anti-SSA antibodies, and it may be drug-induced and has an unpredictable course whenever it is drug-induced, as it may not completely clear after discontinuing the offending drug. A study done by Lawrence Vitz, published in the European Journal of Dermatology in 2017, actually showed that proton pump inhibitors are now the most common offending drug for causing subacute lupus erythematosus. And that's then followed by antihypertensives, in particular thiazide diuretics, antifungals, chemotherapeutic drugs, statins, and anti-epileptics. Tumor necrosis factor alpha antagonists and NSAIDs have also been shown to cause subacute lupus erythematosus. So how do we manage cutaneous lupus? First of all, we need to do a skin biopsy, including immunofluorescence. It's very important for us to do it, for us to be able to document and confirm that there is an interface dermatitis, which usually is more suggestive of the lupus. We need to check for systemic involvement. So our baseline screening for systemic involvement is a complete blood count, urinalysis, electrolytes, blood urea nitrogen to creatinine ratio, ESR, and an ANA. If there's evidence of systemic disease, we need to do our complements, checking for low hypocomplementemia, so low C3, C4, antibodies to double-stranded DNA and anti-Smith. Those are especially present in systemic lupus erythematosus, anti-SSA and anti-SSB, the urine protein to creatinine ratio. And when we are considering a drug-induced subacute cutaneous lupus, antihistone antibodies may be helpful, as they may be positive, but not always. Patients should be screened yearly or more often if the disease is active or progressing. And a chest X-ray and an ECG should also be done. The criteria for the classification of SLE has changed in 2019. There was an updated criteria, and they now suggest that all patients who are going to be diagnosed with SLE must have a positive A&E at some point in time. So they don't necessarily, so the important thing with lupus erythematosus is a spectrum. And they may not have all of the criteria at the same time, which is another reason why it's quite helpful for us to have a biopsy done, because yes, they may not meet the criteria at this point in time, but especially when you have something documented in black and white that they had discoid lupus at some point in time, and which is one of the things towards the criteria, then it may help to fulfill the criteria later on. Patients must have greater than 10 points to be classified as SLE. And as we notice, the cutaneous domain, there's non-scarring alopecia, oral ulcers, subacute cutaneous or discoid lupus, acute lupus, that is there in the criteria. Treatment, sun avoidance. When we say sun avoidance, we don't mean just sunscreen whenever going out. We mean sunscreen every single solitary day, as Dr. Clark alluded to earlier. Sunscreen is absolutely important whether you're going out or not. And we know that lupus erythematosus is a photosensitizing disorder. So they are supposed to wear an SPF 50 or above that is thickly applied. They're also supposed to wear sun protective clothing, broad rim hats, and try to stay out of the sun during the high risk times between 10 to 4 as much as possible. Want to stop any exacerbating medication. Smoking cessation is extremely important, as we discussed earlier, that it makes the course much more severe, as well as the patients tend not to respond to the antimalarials as well once they are smoking. Vitamin D supplementation is also quite useful for everyone and anyone who is doing sun avoidance, as well as it has also been shown to improve the course in these patients. Topical steroids are commonly used, and the strength of the topical steroid will depend on the location of the lesions. So generally use potent topical steroids, especially when we're talking about the limbs, but then on the limbs and the scalp. But if we're talking about the face, then it's going to be a much milder potency. Intralesional injections of corticosteroids may be used, especially for hypertrophic discoid lupus erythematosus, as well as when you have discoid lupus to the scalp. Remember, we said that it's a scarring alopecia, and we have to be very, very aggressive to try to settle down the inflammation quickly so as to prevent more scarring from occurring. Calcineurin inhibitors such as tacrolimus ointment is extremely helpful, especially on the face, around the eyes. Remember, you don't want to be putting a steroid on the face, especially around the eyes, for too long, as this increases risk of cataracts and glaucoma. Patients can be advised regarding camouflage makeup, hair prosthesis can also be advised. Systemic therapy, all patients with systemic lupus erythematosus as well as with discoid lupus should be on hydroxychloroquine unless there's a contraindication, as this has been shown to decrease the severity at which of their symptoms. So especially to decrease the risk of the nephritis and cerebritis. Systemic corticosteroids can be used. Ideally, what you want to do is to start immunosuppressants early so that we can then taper down the dose of the systemic corticosteroids quickly, so you don't have as much steroid-induced hypertension and diabetes developing. The immunosuppressors commonly used are going to be methotrexate, mycophenolate mofetil, and azathioprine. Methotrexate and mycophenolate mofetil has been shown to be superior to the azathioprine, especially in the Black population. Retinoids can also be helpful, especially in discoid lupus. Dapsone can be helpful, especially in bullous lupus. Erythematosus, rituximab can also be quite helpful, and thalidomide, especially in discoid lupus erythematosus. So there was a study, sorry, that was done that showed that 55% of patients responded quite well to hydroxychloroquine. Sorry. And as a matter of fact, when it comes on to discoid lupus, 80% of patients will actually respond well to hydroxychloroquine and topical steroids. The recommendation is to check, to do an EKG or an ECG to ensure that there is no QTC prolongation, especially combining antimalarials with other drugs that have a potential for QTC prolongation, or the patient has high-risk medical problems. So ideally, you want to ensure that the QTC is less than 0.450 milliseconds. The normal is usually 400 to 440. Females may have a slightly longer QTC. You want to check the drugs that you're putting the patient on. Remember, especially antibiotics, the fluoroquinolones, azithromycin, all of the, you want to check all of those drugs. And there's a beautiful website called crediblemed.com that can be quite helpful for us to just check our drugs beforehand, before putting them on that with the antimalarial. Want to also evaluate to see if they have congenital long QT syndrome, if they're elderly, if there's severe acute illness or sepsis on board. They are going to be at a greater risk now for QTC arrhythmias and QTC prolongation, electrolyte abnormalities, obesity, alcoholic liver disease, hypothyroidism, and diabetes mellitus. In cases like this, you may want to give a lower dosage. Antimalarials and the eye, the dosage recommendation is to give less than 5 milligrams per kilogram of the actual body weight daily. And for patients who are at patients who have renal insufficiency, or patients who are also on tamoxifen, may need lower dosage than that and may need closer monitoring. Ideally, baseline examination is supposed to be done within the first few months to rule out retinal disease. So you do not necessarily have to get an eye exam prior to starting hydroxychloroquine. The guidelines do suggest that you can start hydroxychloroquine, but the patient should have a referral to go and see an ophthalmologist, not an optician, an ophthalmologist, to evaluate for macular degeneration or any severe diabetic retinopathy or hereditary disorders of retinal function. The guidelines are suggesting that follow-up can be deferred for 5 years and then yearly. I am still doing yearly, but the most recent guidelines have stated that it can be deferred for the first 5 years once you're going within the weighted dosage recommendation and there are no other contraindications. So case number 2, 45-year-old female who presents to us with facial swelling, generalized pruritus, and muscle weakness. On examination, this patient was noted to have facial edema, and I don't know if you can appreciate this erythema, purplish hue right onto the eyelid here. She does have this purplish hue that is onto the cheeks, the malar region, that is also sparing the nasolabial fold. Can you appreciate also this nail fold erythema that is there, and very ragged cuticles? What you can also get with this condition is a hyperkeratosis and scaling and fissuring towards the lateral aspect of the fingers, as well as onto the volar aspect of the wrist, which is and considered as mechanic hands. Can get that with that. On her thighs, don't know if you can appreciate here this erythematous patch with telangiectasias, and you've seen some hypopigmented macules. This is what we call poikilodermal, where you've seen this erythema, purplish color with it, some hyperpigmentation, hypopigmentation, telangiectasias. And those lesions, when it's occurring on the hip, then that is called the Holster sign. So this patient actually has dermatomyositis. Another common finding, a pathognomic sign of dermatomyositis, is the Gottron's papules or Gottron's sign whenever it is flat. So you can end up with just a purplish macule, can even be vesicular bullous, and then they can become very flat-topped, firm papules over the knuckles and along the sides of the fingers. It can also occur on the elbows and the knees over bony prominences, and this is called Gottron's papules. It's quite pathognomic of dermatomyositis. Can also get periorbital edema, which wasn't that obvious in our patient there. And you can get what is called the shawl sign. So remember that poikiloderma that we had just discussed, especially when it is occurring right along the neck, the shoulders, coming around to the extensor arm, that is called the shawl sign. These patients can be very itchy. This is a cause of generalized pruritus. They tend to present with a lot of malaise, fatigue, and they get proximal muscle weakness. Dermatomyositis is a systemic disorder that's affecting multiple systems. So it can affect the GI tract, causing esophageal dysmotility, can cause reflux to occur. It can affect the heart, causing arrhythmias, congestive cardiac failure. It can affect the lungs, causing interstitial lung disease and acute respiratory distress. So these patients can come in very ill. The most common presentation also is that it causes a proximal extensor inflammatory myopathy. So they have difficulty getting up from a seated position, especially from the toilet, difficulty hanging out clothes, difficulty combing the hair. You may get a flagellate erythema. So you get these very linear, hyperpigmented and erythematous patches onto the back and the upper shoulder, for which there are many other causes of a flagellate erythema. And you can get calcinosis cutis, which you'll also see that in scleroderma, you can get calcinosis cutis, which is where you get this calcium deposit, especially on the fingers, as well as over pressure points. And it can be quite painful. It can even ulcerate. So we already said it's a multisystem autoimmune connective tissue disease, presents with symmetric extensor, proximal extensor inflammatory myopathy, characteristic violaceous cutaneous eruption, pathognomic circulating antibodies. It has a bimodal incidence. Adult form is most commonly occurring between age 45 to 60 years old. And there's a juvenile form, which usually occurs between age 10 to 5 years old. And there's a 2-to-1 female predominance. Up to 40% of patients with the adult form may have an occult malignancy. Initial cancer screening and then vigilant serial monitoring for 2 to 3 years post-diagnosis is extremely important, as the dermatomyositis may actually precede the malignancy being found. So a thorough history should be taken to see whether there are any symptoms suggestive of malignancy anywhere, and patients should have a CT chest, abdomen, and pelvis. The common malignancies that may occur are colon, ovarian, breast, pancreatic, lung, gastric cancers, and lymphoma. It may be associated with other autoimmune diseases, so there may be an overlap. The most common overlap is with scleroderma crest syndrome, and that is called sclerodermatomyositis. With crest syndrome, these patients present with calcinosis cutis, Raynaud's phenomenon. So whenever they get cold, the fingers become numb, cramping, they change to a dusky bluish color and pale. Erythema. Can get esophageal dysfunction, sclerodactyly, so they get a very penciling thinning of the fingers, and telangiectasias, which we'll show you when we go through scleroderma. There may also be overlap with systemic lupus erythematosus, mixed connective tissue disease, Sjogren's syndrome, scleroderma, and rheumatoid arthritis. It's important for us to do the antibodies because the antibodies can assist us with determining one, the severity and the prognosis of the disorder, and to assist as to the screening thereafter, because there are certain antibodies that are at an increased risk of having the malignancies with them, whilst there are other antibodies that are at an increased risk of interstitial lung disease, etc. So the anti-melanoma differentiation associated protein, the anti-MDA5, tends to be associated with interstitial, is a variant of dermatomyositis that is associated with interstitial lung disease, mucocutaneous ulceration, painful palmar papules, non-scarring alopecia, panniculitis, and arthritis. These patients can have a very poor prognosis at times. Dermatomyositis may be drug-induced. Common drugs to induce it is hydroxyurea, penicillamine, interferon beta, and herbal supplements such as isolene has also been implicated. Scleroderma or systemic sclerosis is an autoimmune connective tissue disease that involves sclerotic changes of the skin and internal organs. There's a 3 to 4 times female predominance. It typically presents with very taut, shiny, indurated skin. So quite commonly, before you even notice that, these patients may actually just complain of a hyperpigmentation to their skin. They notice the skin is going dark. And then when you actually feel the skin on the hands, you notice that it's very indurated and thickened, taut. This can progress to the point of them having contractures being formed, and therefore you get this thing called the prayer sign, which is because of the amount of fibrosis, they're unable to put the hands together in prayer, and therefore it is contracted that way. May end up with calcinosis cutis, again on the fingers over the pressure areas, They tend to have loss of the wrinkling of the face, and they get this very beak-like appearance to the face. So the nose gets very beak-like formed. The mouth, you get a microstomia, so it becomes very difficult to open the mouth. May get mat-like telangiectasias, telangiectasias that may occur on the fingers, on the face, on the palms. You may get a salt and pepper appearance, which is where you get a generalized hyperpigmentation, especially over the upper back, and it can also occur on the legs, but then there's a generalized depigmentation, but then there is hyperpigmentation around the follicles themselves. So I don't know if you can appreciate right here. So right where the follicles are, you get this darkness that's coming up right around the follicles, and then you get in this depigmentation that is there. You can also see some telangiectasias in it, which is suggestive of the poikiloderma also. This is a typical salt and pepper, and the skin, usually when you feel the skin, is very thickened and hardened. With Raynaud's phenomenon, the patient may also get digital ulcerations, which can be quite painful for them. The entire arm, so if it is occurring just below the elbow, then that is limited sclerosis. If it is occurring above and it's involving the upper arm as well as the torso, then you know having a more generalized sclerosis or diffuse cutaneous systemic sclerosis. So the three major clinical subsets of scleroderma is a limited cutaneous systemic sclerosis, which is associated with the CREST syndrome. And those patients are at risk for pulmonary hypertension as well as gastrointestinal involvement. So at each visit, you want to ask the patient if they're having any shortness of breath, any shortness of breath on exertion, if they're having any difficulty to lie flat, and you need to get an echocardiogram done to evaluate also for pulmonary hypertension. Diffuse cutaneous systemic sclerosis, those patients are at an increased risk of having renal crisis, cardiac and lung fibrosis, whilst there's systemic sclerosis, scleroderma. So you don't actually, so they have the systemic features of sclerosis. However, the skin is not thickened and taut. A skin biopsy is not absolutely necessary to make the diagnosis of scleroderma. Once you do have skin thickening of the fingers of both hands extending proximally to the metacarpal phalangeal joints, that alone, and you don't have any other features to suggest that it's a scleroderma-like disorder, then that alone can make the diagnosis, because you just need 9 points for you to be able to make the diagnosis. If it's not clear cut, so you don't have like multiple features, you're not having systemic sclerosis related autoantibodies, or you're not having other features, then a skin biopsy can also be quite helpful for you to be able to assist with the diagnosis of these patients. The antibodies are helpful for diagnosis and prognostication. So the ANE is positive in 95% of patients who have systemic sclerosis, but you may just have limited sclerosis. Their anticentromere antibodies can also be positive in limited systemic sclerosis. Anti-DNA topoisomerase, which is anti-SCL70, tends to be positive in the diffuse systemic sclerosis, and those patients are at a high risk of having interstitial lung disease. The anti-RNA polymerase 3 antibodies are positive in diffuse systemic sclerosis, and these patients may have rapidly progressive skin involvement and renal crisis. Other antibodies can also be done to check for overlap syndromes. Additional screening, which should be done, is urinalysis, blood urine nitrogen, creatinine, and pulmonary function test. High resolution CT scan can also be done, looking for your interstitial lung disease. Echocardiogram for pulmonary hypertension. Esophageal gastroduodenoscopy can also be done, looking for gastrointestinal involvement or a barium swallow. Management of these patients, referral to a rheumatologist is important. Monitoring and screening for internal organ changes at each visit is also quite important. You want to advise the patients to keep warm as much as possible, so to carry socks, to use blankets, etc. whenever the time is cold, to minimize the Raynaud phenomenon. You want to encourage patients with reflux to eat smaller, more frequent meals. Proton pump inhibitors can also be used, and antacids can also be used for these patients. Smoking cessation, again, is important. Hypertension from renal disease can be controlled with ACE inhibitors. The Raynaud phenomenon can be treated with calcium channel blockers, such as the nifedipine XL. Emollients and antihistamines can also be very helpful for the pruritus. We can treat these patients with corticosteroids. Usually we don't use high dosage corticosteroids in patients with scleroderma, so as not to precipitate a renal crisis. Immunosuppressants such as mycophenolate mofetil, cyclophosphamide, methotrexate can also be used. Endothelin receptor antagonists can also be used, and phosphodiesterase type 5 inhibitor are very, so the endothelin receptor antagonists are helpful for like the pulmonary hypertension, and the phosphodiesterase type 5 inhibitors, so like the sildenafil, can be very helpful for the Raynaud phenomenon. So let us see if I was successful. Who can tell me, I guess you could type it into the chat, what is this first picture? Where did my chat box go? Ah, here it is. Okay, I'm not seeing any answers into the box. Aha, thank you, Jason, Dr. Thomas, but I don't know if you're really allowed to answer. Okay, thank you. And for this photo here, who can tell me what this patient has? All right, I'm not seeing any answers. So these are my references. And thank you very much for listening. Any questions? Not sure.
The people posted it in the chat.
Ah, okay. I wasn't quite seeing anything else. Sclerodermatomyositis. So for this photo here, these are the features of scleroderma, not necessarily dermatomyositis, but I would actually take it because in the scleroderma, you do have, in scleroderma, dermatomyositis, you do have the scleroderma features. So yes, I will take it, but it is the salt and pepper of the scleroderma. Thank you. This one in the corner. Did anybody remember what that one is? Can you guys see my pointer?
No. Oh, this one.
Right here, the right lower corner.
Lupus profundus.
Very good. Thank you. And this upper one? This one here? Very good. And the last, but not least, this middle one. Not seeing an answer for the middle one.
The picture was taken down.
Ah, my apologies. This one, right? Ah, gosh. This one right here with this face. So acute cutaneous lupus would usually present with malar erythema, not so much periorbital erythema and swelling. So if you're having periorbital erythema and swelling, especially with this purplish hue to the eyelid right here, that is called the heliotrope rash, which you get in dermatomyositis. Thank you, guys. I'll hand over to Dr. Buckland. Any questions?
Yes, I'm looking at the question and answers. Dr. Jerome Stern would like to know if diabetics can take AminoPep.
I think that was for our Indus rep, but yes, to my knowledge, they can.
And Dr. William Brown says, what to do next if the ANA is negative in DLE, discoid lupus?
So if the ANA is negative, and there have no other signs of systemic disease, then it is a matter of still treating them with topical corticosteroids. We usually still add the hydroxychloroquine to these patients so as to decrease the risk of them developing systemic lupus erythematosus. And then they still must be screened yearly with their bloods to see whether they have developed systemic lupus, and you'd screen them before if they're starting to have symptoms.
Thank you. He also wants to know what do you do when the when there is high complement C3, what does this mean for these borderline patients?
Honestly, I'm not quite sure. For the high complement C3, it usually, whenever there's an acute flare, then the C3 tends to be low. It may have to do with some other immunodeficiency disorder.
Okay, so when there's a flare, the C3 tends to go low. Okay.
Low. So if there's a flare, it's low, not high.
And what to do next if the clinical SLE spectrum is made, but a negative biopsy is obtained?
We still manage the patient because that biopsy may have been done when the lesion was resolving. And we could biopsy the lesion, a new lesion later on. But if the clinical SLE spectrum has been made, then there's no need really to try and get the biopsy to be made. We manage the patient as such.
Right, okay, important to know that. And could early vitiligo herald future systemic lupus?
So vitiligo is more, it's not necessarily, yes, it's an autoimmune disorder, but typically it's not so much associated with SLE per se. So it's actually more associated with Hashimoto's thyroiditis, pernicious anemia, other autoimmune illnesses. But it's not that if someone has vitiligo, then they are at a great risk of developing SLE. With that said, once you have any autoimmune illness, you are at a greater risk of having any other autoimmune illness.
And if hydrochloroquines are not available due to COVID, what do we do to replace? What can we use to replace them with?
We would use one of the other immunosuppressants, whether it be methotrexate, mycophenolate mofetil, azathioprine. And again, that's dependent on what we're treating. It depends on what the patient's profile is like, because we know like methotrexate is not as helpful in the skin for the systemic features of scleroderma, whilst it can be quite helpful for the skin findings for scleroderma. But if the patient has, for example, systemic features of scleroderma, then you'd prefer to go with something more like mycophenolate mofetil. If the patient has, for example, dermatomyositis and they're having interstitial lung disease, methotrexate, again, may not be your first choice, just because methotrexate can also cause interstitial, can cause pulmonary fibrosis. With that said, you have to weigh everything because it depends on cost, what the patient can also afford.
Mm-hmm. Is there any connection between dermatomyositis and H. pylori-induced GERD?
Not to my knowledge. No, not to my knowledge that there is an increased risk of H. pylori GERD with dermatomyositis. They tend to have reflux because of the dysmotility that occurs because of the amount of fibrosis that is occurring within the gut itself, but not necessarily that there is an increased risk of H. pylori as far as I'm aware.
Mm-hmm. And what is the best approach in treating mixed connective tissue disease?
So when you say the best approach in treating mixed connective tissue disease, as in which overlap, what are the features they're having? You know, it all depends on the features that they are having. Usually we start off with oral corticosteroids. That's going to help to settle things down, and we quickly try to start an immunosuppressant depending on what the patient's profile is. Again, if there is no liver impairment, if there is no anemia, etc., you know, we choose the immunosuppressants based off of that.
Thank you. person would like to know, could you repeat how to prevent a patient with systemic lupus from developing diabetes?
So you want to try and get the dosage of the steroid down as quickly as possible. And for you to do that, you would have to add the other systemic immunosuppressant as quickly as possible, because they take somewhere between a month to 3 months, depending on which one you've selected, to start to have its greatest efficacy, put it that way.
Okay.
So as much as possible, patients with systemic lupus should not be on these high doses of corticosteroids for months on end. Ideally, within the 2 weeks, you want to try and start getting the dose of the prednisone lowered.
Okay, thanks. Could you bring back your post-test in your picture form, please, so that
Sure.
the audience. Right. So the first one on the left, what did you
That
say
one.
that was?
Palmoplantar discoid lupus erythematosus.
Okay. And so we're just having the answers now. And the one in the middle at the top?
This is features of scleroderma, in particular the salt and peppering of scleroderma.
And the guy at the bottom in the middle?
This is dermatomyositis, showing the heliotrope rash. That's right here. The periorbital edema, that is right there.
And the top right?
Subacute cutaneous lupus, showing the very annular polycyclic papillosquamous plaques.
And the one at the bottom?
Lupus profundus, which is where you're having discoid lupus on top of a panniculitis. So you're getting this very sunken atrophic patches that are there with the erythema that's there.
You know, I really appreciate your presentation. I know it has been quite broad, it's quite extensive, and you did a magnificent job covering such a wide range of areas that are relevant to us. I remember many years ago, you're welcome, one of my patients actually presented with a thickened lesion on her forearm, and she was rubbing garlic on it, wanting it to go away, and then she came and showed it to me. I said, we just want to take it to the dermatologist and let them look at it and take a biopsy. And it was lupus profundus.
Yes.
And what was interesting, you know, when I was checking her out for other things, she couldn't see a certain part of her visual field. And when she went to the ophthalmologist, she actually had choroid melanoma. And of course, they had to take out the eye. Yeah, it was quite in the one person, you know. But she was an amazing individual. And I said, well, what are you going to do? She says, I'm taking out the eye out of my life.
Yeah,
So,
that's the most important thing, life.
So we have our patients, they come manifesting different things, but just remember, all of us, that we are treating people, and they have feelings, and it's how we tread this journey with them so that they can have as an amazing life as possible. Thank you so much, Dr. Graham.
You're most welcome. Take care, Dr. Buckland.
Thanks. Our next presenter is going to talk on a very important topic: dangerous drug eruptions, pearls and pitfalls in diagnosis. To present to us is Dr. Lorena Muir-Green. She is a consultant dermatologist who graduated from the University of the West Indies, first obtaining a double major in chemistry and biochemistry in 2002. Then she went on to pursue a career in medicine at the University of the West Indies and graduated in 2007, and then pursued her postgraduate specialization in clinical dermatology at Cardiff University, for which she got distinction. She was a recipient in 2013 of a fellowship in hair scalp and inherent scalp disorders at the University of British Columbia. And she is a member of the North American Hair Research Society, International Society of Hair Restoration Surgery, and a member of the Caribbean Dermatology Association. She's a past president of the Dermatology Association of Jamaica and is an associate lecturer in dermatology, UWI. She's the head of the dermatology at the Cornwall Regional Hospital, Montego Bay, where she conducts a once-a-month hair and scalp disorder clinic. She also conducts a hair loss clinic at the Dermatology Clinic at the National Chest Hospital in Kingston, which she started in 2014. She has presented at various conferences, including the American Academy of Dermatology, Caribbean Dermatology Association, Medical Association Jamaica's Annual Symposium, American Hair Research Society Annual Meeting. We can see from all of this that she is a very keen dermatologist, and she has a keen interest in cosmetic chemistry and hair care. Through that, she has established a blog on the science of hair loss and hair care on www.askthehairdoc.com with associated media pages. She can also be found as Dr. Lorenia Muir-Green on Facebook, Instagram, and Twitter. So here to present to us is Dr. Lorenia Muir-Green on dangerous drug eruptions, pearls, and pitfalls in diagnosis. Dr. Lorenia Muir-Green, the wheel is yours.
Good afternoon, everybody. Thank you for having me and thank you for inviting me to present. I'm going to try to share the screen. It's saying that I can't share right now. Okay. Everybody hearing me well?
Loud and clear.
Okay, good. So today I'm going to be discussing dangerous drug eruptions, pearls, and pitfalls in diagnosis. And I just wanted to say that this is a very broad topic to have to do in 30 minutes. So I went over some of the most salient points so for persons to remember. So today we're going to be looking at the types of drug reactions, and we're going to be looking at specifically Stevens-Johnson syndrome, TEN, toxic epidermolysis necrosis, drug rash with eosinophilia and systemic symptoms, and acute generalized xanthomatous pustulosis. So, as you know, there are the classification of adverse drug reactions, and the type 1 is the IgE mediated, which is immediate in onset and mediated by IgE and mast cells and or basophils. Typically get urticaria as well as angioedema happening with these reactions. Type 2 is cytotoxic, this is generally rare, delayed in onset and caused by antibody, usually IgG mediated cell destruction. Type 3 is immune complex, which is delayed in onset and caused by IgG drug immune complex deposition and complement activation. Type 4 is delayed cell mediated, and that is delayed in onset as well. Right. So type 1 reactions require the presence of drug-specific IgE, and they are usually dose dependent. Intravenously administered medications may cause symptoms in seconds to minutes, while those that are orally administered can arise within 3 to 30 minutes if on an empty stomach, and within 10 to 60 minutes if taken with food. The classic wheel and flare are hallmark signs of mast cell degranulation, and clinical features are usually urticarial rash, angioedema, of the extremities, the face, as well as sometimes don't forget about abdominal angioedema, where patients will present with colicky pain. Anaphylaxis is the most severe presentation of this reaction. Type 2 reactions are uncommon and involve antibody-mediated cell destruction when drugs bind to surfaces of certain cell types and act as antigens. Clinical manifestations require the presence of high titers of preformed drug-specific IgG or rarely IgM antibodies. The specific IgG or IgM antibodies are directed at drug hapten-coated cells. Symptoms usually appear at least 5 to 8 days after exposure, but may begin after much longer periods of treatment. Usually present as hemolytic anemia, thrombocytopenia, or neutropenia. Type 3 reactions are mediated by antigen-antibody complexes that precipitate in various tissues, including blood vessels, joints, and renal glomeruli. They are uncommon and usually seen in high-dose prolonged drug administration, similar to type 2 reactions. Signs and symptoms take 1 or more weeks to develop after drug exposure, since significant quantities of antibody are needed to generate the symptoms. Re-exposure to the same drug can cause a more rapid and severe reoccurrence, and clinical presentations include serum sickness, drug-induced hypersensitivity, vasculitis, fever, arthralgias, and glomerulonephritis. Type 4 reactions, which we're going to go into more detail for this presentation, involve the activation and expansion of T cells, which requires time, hence the name delayed type hypersensitivity. There is presentation of drug molecules to T cells with cytokine and inflammatory mediator release, and there are recognized patterns of cutaneous involvement, including contact dermatitis, morbilliform eruptions, and severe exfoliative dermatitis, including Stevens-Johnson syndrome, toxic epidermolysis, necrosis, DRESS syndrome, and AGEP, which is acute generalized xanthematous pustulosis. So the first one we're going to be discussing today is SJS-TEN. This is a spectrum of life-threatening mucocutaneous disorders and initially thought to be separate processes, but as you know, said that it's now recognized as similar processes defined by the involvement of body surface area, and it involves extensive necrosis and detachment of the epidermis and mucosa. It is considered a dermatologic emergency. So, as I said before, the definition is determined by the body surface area. Less than 10% is considered SJS, 10 to 30% SJS-TEN overlap syndrome, and more than 30% is TEN. Before the rash appears, there's usually a prodromal illness of several days duration, resembling upper respiratory tract infection or flu-like illness, and these include fever, sore throat, difficulty swallowing, runny nose and cough, sore eyes, and conjunctivitis, and general aches and pains. The cutaneous lesions tend to begin with a burning, painful eruption, and the maximal extent of lesions usually occur within the first 2 to 3 days. So you will see how much of the body surface areas is involved within the first 2 to 3 days. Mucous membrane involvement presents in nearly all patients with SJS-TEN, involving the oropharynx, eyes, genitalia, and anus. Fever may be present, and GI or tracheobronchial epithelium can be involved, and we've actually had a patient cough up their esophagus before. There's a cephalocaudal progression. Presentation can be multitude or multiple, because you can have macules, which are flat, red, and diffuse, or measles-like rash, and diffuse erythema, targetoid lesions, which is the most common presentation that most people will see, similar to erythema multiforme, flaccid bullae and blisters, which you will also quite common presentation. And then these blisters then merge to form sheets of skin detachment, exposing red oozing dermis. The Nikolsky sign is also positive. So this is a patient that we had recently on the ward who developed SJS-TEN overlap syndrome when she was given dilantin for her epilepsy, new onset epilepsy. As you can see, there is involvement of the eye, well, barely any, there's conjunctivitis there, and she has, as you can see here, erosion, crusted erosions on her lips, and you will see the morbilliform eruption on her legs, and here she has confluent morbilliform as well as targetoid lesions on her back. This is a picture that I captured from the internet. As you can see, this is a person having a TEN at this point, where there is actually denuded skin. Another patient here who also captured from the internet, where you can see the loss of skin from allopurinol. That's what the patient was on. So differentials include severe cutaneous adverse reactions, such as DRESS syndrome, staph scalded skin syndrome, which is more seen in children, toxic shock syndrome in more adult females, erythema multiforme major with mucosal involvement, and mycoplasma infections, bullous lupus erythematosus, which actually confused some people sometimes because they're thinking, oh, it's a drug reaction, but if it's lasting more than 2 weeks, then definitely it's not. And then the patient is getting medication, more than likely it's not. That is more than likely bullous lupus erythematosus and paraneoplastic pemphigus. So in investigating these patients, we tend to do the complete blood count. Anemia is usually present. Lymphopenia is commonly present as well. There's usually no presence of eosinophilia or atypical lymphocytes. The presence of neutropenia is indicative of poor prognosis. In the urea and electrolytes, there you want to take a look at the potassium, especially because they're at risk for hyperkalemia, and that is the reason that one of the main reasons that they could die instead of the actual disease itself. In the liver function test, they can have elevated transaminases, which tend to lag behind the resolution of the skin. So don't be too worried if the skin heals up and they're still having elevated transaminases. It will slowly come back down with time. A skin biopsy, which you tend to do in hospital, tends to give the best way to diagnose, because as I said, it can look like any of the other severe cutaneous adverse reactions, and it just helps with the diagnosis. So in managing a patient, we give IV fluids, but we don't use the same, mainly crystalloids, and we don't use the same calculations as those we use in burns victims, because what will happen is that they become extremely edematous due to the loss of protein from the shedding of the skin. We tend to do in hospital, allow most of the fluid to be administered orally, and this reduces the chance for the development of edema. Ideally, should be in a burns unit, which we don't really have. We also do a sepsis screen, blood culture, urine culture, and skin swab, and we start them off on empiric antibiotics until we get back the results. Ophthalmology is consulted to ensure that the eyes are not really involved, and if they are, they do rodding as necessary. We have a nutritionists come in to actually give them a high protein, high fat, high calorie liquid diet, because as you know, they're losing everything, all their nutrients, everything are going away, and so they have to be replaced. Any other consultation is necessary, including ENT, gynecology, urology, and we use mouthwashes with lidocaine to help with the oral symptoms. Try to keep them warm as possible, because as you know, they've lost their skin, and so the thermal regulation is gone, and so they're cold all the time. We give them, for the erosions, we can either use the topical antibiotics, such as mupirocin or fusidic acid. We also, when we do dressings, we use dressings that are non-adhesive, and we also use topical corticosteroids to help with the skin, especially with SJS more than a TEN. Prednisone, the use of this is still controversial because it hasn't been truly been shown to be the most beneficial way to treat it. However, this is what we have readily available out here, so we tend to give patients prednisone. IVIG, readily available in the public sector, very expensive to use in general if you're in the private setting. but it is recommended to give it within the first 3 to 5 days of development of the rashes. Biologics have also been used, especially abroad. Patients who have poor prognosis include patients of increased age, female sex, persons with comorbidities such as hypertension, autoimmune diseases, and high percent body surface area involvement, as well as septicemia. So what I want you to remember about with SJST, and now we have the score 10 and other scoring systems that we use in the diagnosis. But really and truly, what I want you to remember is this: the extent of involvement is maximal by day 3. So you know how much of the skin is going to be involved by day 3. So if you have somebody who walked in with just oral ulcers and crusting on the lips, and you weren't too sure because that's all they came up with, if within, let them know that if they start to develop any other rashes, then they need to come back in so that you can be seen, or tell them to go immediately to the hospital. Of course, you need to send these patients to the hospital as soon as possible, because this is not a wait and see situation. Not checking for genital and perianal involvement, because fusion of labia can occur, and this has happened, unfortunately, in one of our patients a long time ago. Urethral strictures can occur in both men and women, and perianal strictures can occur. Catheterization helps prevent urethral strictures. Patients can die from hyperkalemia, so of course that must be monitored closely, and of course thermal regulation is needed. Just a brief word on the erythema multiforme story. So as it's still brought up in when you look online about SJST, and erythema multiforme is still considered kind of sort of part of the spectrum, but really and truly erythema multiforme, where you just have the targetoid lesions and the erythema, usually is actually due to viral cause, especially HSV1 or 2, and those persons need to be investigated. All right, and it tends to be recurrent in most of the cases. Now, in that doesn't preclude that somebody who presented with erythema multiforme major or SJS did not have HSV1 or some other conditions such as HIV. It doesn't preclude that, but I'm just letting you know that erythema multiforme is not necessarily seen as part of it, but it's still considered part. On to the next one, DRESS syndrome, which is a rare, potentially life-threatening drug-induced hypersensitivity reaction that includes rash, hematologic abnormalities, mainly eosinophilia, lymphadenopathy, and internal organ involvement. There's an incidence of 0.9 per 100,000. The frequency varies depending upon the type of drug and immune status of the patient. Mortality rate for DRESS is between 5 to 10%. Most cases occur in adults without sex predilection. The pathophysiology is unclear. DRESS is primarily a drug-specific immune reaction acting as a trigger of viral reactivation by as yet unknown mechanisms. So they think that there's an initial event in DRESS, which is clinically inapparent viral reactivation that induces the expansion of a T cell population cross-reacting with the drug. There's a Japanese group that has put forward that that testing for human herpes virus 6 reactivation is useful for diagnosis. However, as this is likely to occur 2 to 3 weeks after the onset of the rash, a diagnosis may be missed if reactivation is not measured at the correct time. There is also a debate as to whether the reactivation is part of the syndrome or is a complication. So as you know, the most common causes for DRESS is actually drugs. Main drugs, the anti-epileptics, and there's a strong HLA association. So this is a pie chart showing the most common drugs that we see causing DRESS syndrome. Again, it develops 2 to 8 weeks after starting the offending drug, and the mean onset is 3 weeks of taking the drug. If re-challenged or re-exposed to the offended agent, it can develop within 1 day of exposure. Symptoms may flare even after 3 to 4 weeks of stopping the agent. The extent of skin involvement is not an indicator of how extensive internal organ involvement is. So this is very important for you to know this. The risk of DRESS may be as high as 25% for individuals who have a first-degree relative or who has experienced this syndrome. Autoimmunity may develop as a sequelae. So the registry for severe cutaneous adverse reactions, inclusion criteria for potential cases require at least 3 of the following: hospitalization. So most of our patients who develop this actually are already hospitalized. So, you know, they've given a barrage of medication for whatever the presentation they came in with for, and then it suddenly developed the rashes. Reactions suspected to be drug-related: acute skin rash, fever about 38 degrees Celsius and above, enlarged lymph nodes at 2 sites, involvement at least 1 internal organ, and blood count abnormalities such as low platelets, raised eosinophils, or abnormal lymphocyte count. So differentials include Stevens-Johnson syndrome, toxic epidermolysis necrosis, acute infection, acute T-cell lymphoma, other immunological disorders such as Kawasaki disease or juvenile rheumatoid arthritis. Now, these are the main organs that can be affected. Liver being the most common, and the second most common is the kidney, and then the lungs. So with organ involvement, you may get hepatomegaly and jaundice. Most often the hepatitis is asymptomatic and detected by routine liver function tests. Severe impairment is the cause of the majority of deaths in DRESS. For the kidney, there can get acute interstitial nephritis, often induced by allopurinol. Renal abnormalities include a moderate increase in creatinine level, low-grade proteinuria, and abnormal urinary sediment with occasional eosinophils. Advanced age and pre-existing renal disease may be predisposing factors. For the lungs, it can present with cough, fever, and tachypnea dyspnea. Other organs that can be involved include, as listed below, thyroid. You can get an autoimmune thyroiditis, pancreatitis, uveitis, etc. So this is a patient that we had on the ward. She had been given Augmentin, and she developed DRESS syndrome. So as you can see, not the best photos, unfortunately, but she actually had a more biliform eruption with a extensive erythema. So in our investigations, we would typically do this complete background ESR CRP, blood film, viral serology, if available, to exclude alternate diagnosis, blood culture, any serology for hepatitis, and lymph node biopsies if necessary. We can do CT scans and abdominal ultrasound as well as skin biopsy to confirm the diagnosis. In the treating the disease, we discontinue the offended agent. Systemic steroids may need to be continued for several months with very slow tapering of the dosage to avoid flare. IVIG has also been reported as being effective. However, again, there are no trial data to support this. Symptomatic management, including the use of topical corticosteroids, antihistamines, IV fluids, and nutritional supplementation. Pearls and pitfalls, these are what you need to think about when you encounter such a patient. The skin eruption and visceral involvement generally resolve gradually after drug withdrawal. Eruption is typically more biliform but can have other presentations. The risk is higher in people who have a first-degree relative who has had the syndrome co-infection with human herpes virus 6, Epstein-Barr virus or CMV, cytomegalovirus. The skin eruption may not indicate the severity of organ involvement. Organ recovery may lag after skin recovery, especially with liver involvement. Signs of myocarditis may be silent, and you must have a high clinical suspicion, should do ECG and assess cardiac enzymes and tropi as soon as possible. Patients must be closely followed up for organ impairment long after resolution of their symptoms. And as said before, patients are at risk for autoimmune disease and need to be followed up closely. And remember, when you're doing your autoimmune screening, most doctors have a tendency to just do the ANA, double-stranded DNA, CRP and ESR, and the complete blood count, and the LFTs and UNEs. However, just want to remind you that sometimes it has also been recommended to do the autoimmune antibody panel, because sometimes the person can be negative, have a negative ANA, but actually be positive to some other autoimmune disease like scleroderma with positive SCL70. Just want to let you know, just to remind everybody about you have to be careful about the lab that the patient has went to do the blood test. Now, for the anti-nuclear antibody, there are two main types of testing that is done. The ELISA, which is less specific, and a lot of patients could be full on autoimmune and be negative with this method. It's a cheaper way to actually test it, so that's why most labs out there use ELISA. Now, the immunofluorescent antibody method is a more accurate method. It gives you a titer, it gives you the pattern of distribution, and so you will know if it is by the pattern. If it's homogeneous, you are more likely to have lupus. Others patterns such as centromere could indicate systemic sclerosis, etc., etc. I've told you guys before that only 4 labs do the IFA. So if you suspect that the person is definitely developing an autoimmune disease and they did the ELISA, you can repeat the ANA at one of these labs that offer IFA. These are the UE lab, National Public Health Lab, Biomedical, as well as Central Medical. Those are the ones that tend to do the IFA method. Also, don't forget to do the rheumatoid factor, as well as the thyroid function test. On to AGEP. This is as said before, this is acute generalized xanthomatous pustulosis, and it is a rare type of severe cutaneous adverse reaction. Like other scars such as Stevens-Johnson syndrome and TEN, as well as DRESS, AGEP is a type 4 hypersensitivity reaction. The T-cell mediated response in AGEP results in neutrophilic inflammation, but there can be some overlap between the different types of scar, and patients may have clinical features of, say, SJS, TEN, or DRESS with AGEP. It is caused by drugs in 90% of cases. 10% of cases are associated with infections such as parvovirus B19, cytomegalovirus, mycoplasma, or and other causes can be undetermined. AGEP is a T-cell mediated neutrophilic inflammation involving drug-specific CD4 positive T cells, cytotoxic CD8 positive T cells, and inflammatory cytokines and chemokines. So these are partial list of agents that are causing AGEP, and the most common ones that we have seen out here are the use of your beta-lactam antibiotics, such as your penicillins and cephalosporins, right? So AGEP is characterized by the rapid appearance of sterile and non-follicular, meaning it is not around each hair follicle, pinhead-sized pustules on an erythematous base, typically starting on the face and skin flexures before becoming more widespread. Usually starts rapidly up to 2 days of starting the offending drug, and with some medications, onset may occur up to 2 to 4 weeks of starting same. You can typically have a fever in the acute phase, and there's elevated neutrophil count, which is quite common. Internal organ involvement is quite rare, and eosinophilia a mild increase in serum transaminases or reversible reduction in the creatinine clearance can be found in a few patients. Secondary skin infection as well as hypocalcemia may occur in older or immunocompromised patients. So this is what you will see. So when you are looking at you will see this eruption of pustules, and they are sterile, so they don't grow anything when you actually culture them. And they're usually around, they are not around any hair follicles, unlike bacterial folliculitis, okay? And they also are on an erythematous base. So again, differential diagnoses include pustular psoriasis. Usually patient will have a history of psoriasis, and there's a longer duration rather than, they have it for weeks to months rather than just a few days. Subcorneal pustular dermatosis, which have larger flaccid blisters and less acute clinical course, and pustular vasculitis, where you have bullous and or pustular lesions in purpura of leukocytoclastic vasculitis. And those are localized mainly on the dorsum of hands. So with AGEP, we usually investigate with complete blood count. And as you would say, as I said before, you mainly have neutrophilia. Eosinophilia, may be present, especially in overlap AGEP dress. You can have raised ESR-CRP, raised transaminases, and skin biopsies. You can see the subcorneal pustules or neutrophils. Sepsis screen may not be necessary, as again, I said, the skin swab, there's no growth, and patch testing can be done after the person has resolution of symptoms to confirm the allergy. Most patients recover from AGEP within 10 to 14 days of withdrawal of the causative agent, and the pustular eruptions discommit during the recovery phase. The mortality rate from AGEP is approximately 2 to 4%. The treatment is mainly symptomatic with topical emollients, corticosteroids, oral antihistamines, and analgesics for fever management. Now, pearls and pitfalls for AGEP. The antecedent medication history is usual giveaway of AGEP. Generally, the patient is well, because most of the time we've had patients walk into clinic with AGEP and they were quite fine. Typically, it starts in the folds, mainly the axilla and the groin and the space before spreading outwards. Pustules are non-follicular, that is, they're not around each hair follicle, unlike bacterial folliculitis. Pustular psoriasis, a patient may have a history of psoriatic arthritis, or the lesions last more than 15 days. Administering drug may cause more severe reaction with organ involvement. Now, just for overview, Scott, I wanted to keep it in time, and I'm actually on time. Want to remember with approach to severe cutaneous adverse reactions, you want to take a very detailed history. A lot of times when they're referred to the hospital, we just said the person started on a drug rash, having a potential drug rash, and there's no actual listing of any of the drugs that the patient is on a daily basis, or any of the new drugs that they may have started, which is kind of frustrating. You need to establish a detailed drug timeline. This is quite helpful in terms of delineating the most likely drug to cause the drug reaction. Ask about all drugs, including painkillers that they may just take every now and then, including paracetamol, because we've had persons with TEN develop from paracetamol. Herbs and other supplements, because we love in Jamaica all our herbs and bush teas and everything like that. Use of vitamins such as and other supplements such as fish oil, vaccines, which is highly topical now that everybody is getting vaccinated for COVID. Viral exposures, of course, COVID-19 is one of them that can present like this. Herpes simplex virus, HIV, Epstein-Barr virus, some of the viral entities that can present with a severe cutaneous adverse reaction. history of autoimmune disease, or if you suspect that the person may have this, it's beneficial to elicit this in the history. And of course, any family history of a severe adverse reaction may potentially indicate that this person has a similar reaction as well. Okay. Thank you.
I'm going to say, wow, that's a marathon. Thank you very much, Dr. Green. All right, now we have some questions. So now,
Not sure, I'm not seeing any questions here.
actually, I don't see any questions posed for you.
Yeah.
No. You want to pose a kind of a case history that would bring in some of the points that you brought up in your presentation? Somebody that you saw that you think would be very interesting, like may have come to us, and how to get the person helped as early as possible? Can you think of a case like that?
Yeah, sorry, say that again, please.
I was asking if you had any cases that were referred to you. I know you'd have several, many, that would have come through the private family doctor, and that when you look at it, you know, what we could have done differently to get the person to you faster, or what we could have done differently that would help in the person's recovery.
Actually, I don't have any such case, to be honest, because most of the time when persons present, they actually present to hospital within a very short period of time of developing symptoms. Most GPs are quite aware of, it's looking of the presentations, and they're like, okay, this is definitely a severe reaction, send you off to get hospitalized as soon as possible. The only thing that we have to remember for prescribing is that a lot of times when a person comes in with new onset seizures, we have a tendency, especially to start them off with phenytoin or dilantin, which is notorious, one of the most notorious agents for developing these reactions. And of course, allopurinol is the second one of the, in addition to, of course, your the penicillins, etc., that are most commonly associated with these reactions. Allopurinol is up there as in one of the most common things that medications that we see that develop, patients develop these severe reactions. So I'm not quite sure what else to add to it, to that.
I agree with you. I remember one of my patients sent me a photo of an eruption that occurred on her mom's skin. It's not to my patient, and she told me the drug she was on some antiepileptic, and I said, it was during curfew. I said, it doesn't matter, just go take your mom right now to the emergency department, because she's elderly, and because she hadn't been to see me at all. I said, just take the medications up to the emergency department, and they will, if they can't handle it, I'm sure they'll call the dermatologist. And I think she did pretty well. You're right. Many of them just go through A&E.
Right. Most times we don't have a problem with persons presenting. The issue is the history of the drugs, because a lot of times we've had where patients come in from the health center and they're not aware of the medication. So one patient we had the other day with she actually had that one that I showed earlier with the Stephen Johnson. She was a poor historian, and no one seemed to know what medication she was taking. She was reported a diabetic. She was also hypertensive, and no one knew what drug she was on. And so it was a little bit difficult trying to figure out what was the cause, whether it was a new medication that she was placed on or any of the ones that she was on before, or if it was just a switch. You know, if the we also sometimes people forget to tell us that they actually switched to a different drug, and so you know, sometimes our patients get confused and then end up taking a drug that they weren't supposed to be taking. They were switched to another drug, and because they, you know, the hypertension was not responding, and the blood pressure was not responding to whatever drug, and then they were switched to whatever, and then they went back to the old drug by accident because it was lying around, and then they developed the drug reaction. So a lot of, those are the main issues that we have, is just the actual drugs that the patients are on, how long they were on for. That's the main thing that we have issues with. But other than that, most doctors, they are able to pick up that, okay, something, this is a severe reaction, then they need to be sent off to the hospital.
Yeah, I agree with you. Let's see if there are any other questions coming through. Let's see. No other questions. Okay, do you have questions for the group then?
Not at this time. Not at this time.
I think it was I tell you, you did a marathon, and I had to do screenshots along the way so that I can go back over what you had presented. And thank you so much for your presentation. It was quite well researched, and I know that you had to present a lot in such a short space of time, and we really appreciate you taking time out of your busy schedule, because I can see how busy you really are, to come and help us. And to know that you do have clinics at National Chest Hospital and also at Montego Bay Hospital. And I guess if people needed to follow you, they'd follow you also online, because you said you had a blog. You have a blog. And
yes, I do. Just want to remind persons of where all of our locations are island-wide for dermatology.
right.
So we have National Chest Hospital, which serves most of the majority of the island. We also have in the Western region a regional service. So we have most of our clinics at Cornwall Regional on Mondays, Thursdays, and Fridays. And on the Tuesdays, we go peripherally to the different parishes. We go to Falmouth Public General at once a month, and that's the second Tuesday of every month. For now, we had to scale back because of the second wave. We were actually going twice a month, so we scaled back. So we're there second Tuesday of every month. We go to Noel Homes the first Tuesday of every month. We go to, on the third Tuesday, Darliston Health Center. On the fourth Tuesday, which is an afternoon clinic, we go to Sav Health Center, as well as White House Health Center, which is where I typically see most of my Hansen's patients.
Where's that last health center you go to? You said Sav and
White House.
White House.
And those are both afternoon clinics.
Mm-hmm. In the afternoon. Okay, so if people need to make appointments, they go through the health center or the hospital.
Yes, just refer, just send, and they will come. Just send with a referral, and that's fine.
Right. Okay, thank you so much. Just checking that there are no more questions. Oh, what did this person say? No. Oh, somebody, oh, Dr. Soup, is co-amoxiclav more likely to cause reaction than Pen B?
That is a good question. No, actually, I'm not entirely sure. I'd have to go give you back that answer a little later. Yes.
And what, sorry, go ahead.
Yes, continue.
The other one is, what drug do you suggest for seizures?
Well, as they know, it's directed by the type of seizures, but we get a lot less than the phenytoin with the carbamazepine than the phenytoin, because most of the times when everybody goes straight to the phenytoin, we get a whole lot more than say carbamazepine or
So you think just preferably to use a carbamazepine then?
Yeah.
Preferably. Okay. All right. Thank you so much. All right. Let me stick to schedule. All right. So thank you so much, Dr. Lauren Green, and also to Dr. Graham. At this time, I'd like to turn over to Dr. Donald Gordon, who will move the vote of thanks.
Okay. All right. Thank you very much. Thank you, Aldit, for piloting the session. And very thanks to our audience for staying engaged on what is an interesting, fruitful, and beautiful afternoon. We know you could have gone somewhere else, but we thank you for choosing our presentation. Thank you very much to the presenters, Dr. Clark, for extensive treatment of the acne topic, and we certainly learned a lot in terms of our refreshment. Dr. Stephanie Matthews, very interesting presentation on acral lentiginous melanoma. For some of us, the material was new, but we certainly enjoyed it. Dr. Graham, we thank you very much because you did a very pointed presentation on what is an extensive topic. And thank you very much to Dr. Green for bringing us up to date with some of the problems that can occur with drug eruption. Know that it's a very important topic. And I remember a patient of mine who was allergic to sulfur, and she was diabetic, and she was from one sulfonylurea to the other by a doctor, and she ended up in hospital because apparently the doctor didn't realize that she was having a reaction to sulfur. So I know that important topic. Thank you very much to our sponsors. We thank the title sponsors for the first section, Arista Farm. We thank you very much for your support, and we thank us for their support for the second session. So thank the other Medintech, Jan. Thank you very much for your support. Just necessary this time to get the sessions going. Thanks for your moderating and your prayers. Thank you very much as well for your loyalty and support. We thank Lynn, our administrator, who has done so much to contact the presenter, the sponsor, and getting everything together. We thank the technical team from Allgate, Carrie and Sam, for the usual ensure that we have a very technical session. Thank you all for the afternoon with us, and we look forward to your company once more. The 20 minutes, we have a ethics, and it concerns the vaccine. Topical content. Everybody drink. For the session on July 29th, so Thursday evening at 6. It promises to be a very interesting session. We have some very interesting presenters who will be on the session. We have Lloyd Distance, Jamaica Chamber of Commerce, Ellen she's a trade unionist, and we have some Mr. O'Neill Grant from the Jamaica Civil Service Association. So please listen out for that session. It will be July the 29th. And thank you very much for your attendance this afternoon.